morning. My name's Joy Hoskins. I'm the Director of Nursing for the Department for Public Health. Thank you for joining us today for our February 18th, 2016 Public Health Nursing ITV. We've got a great agenda planned, and all of our speakers, I think, are here or lined up, and we've got our presentations loaded and ready to go. I did receive 3 emails this morning from some nurse leaders who did not receive the handouts. Those went out Tuesday evening from me, and then yesterday late afternoon, the Legionnaire's disease presentation went out. So what I'll do is after Teresa Wren starts her presentation, I'll go back to my office and resend those out to make sure that everyone has received those. So without further ado, I'll go ahead and introduce my friend and colleague, Teresa Wren, who is the director of the Diabetes Prevention and Control Program. And Teresa's going to speak in coordination with her team members, Kim DeCoste and Janice Hale, who is actually in Owensboro this morning. She's going to be looped in with us via ITV. They're going to be doing a presentation on evidence-based practices in diabetes to improve diabetes outcomes in Kentucky.
There we go.
So thank you again for joining us, and I'll turn it over to Teresa. Thank you.
All right, bye-bye.
And if you haven't already muted your mic, if you wouldn't mind to go ahead and take an opportunity to go ahead and do that right now for us. There you go.
All right.
And there's you can either hit that button or the one over here on the top right.
All right.
Thank you. Thank you, Teresa.
Well, good morning, everyone. I try to be prepared for my close-up today, but I never am too happy about that. I try to stand as far back as possible. But thank you for allowing us to speak today. As Joy said, our objective for today is going to be to talk to you about evidence-based interventions related to improving outcomes in diabetes here in Kentucky. And in particular, we want to talk to you about evidence-based interventions, as the title indicates. But first, we're going to do a little bit of background, because, you know, we're public health people and we need to talk about data, right? But I promise I won't make your eyes glaze over too badly. But we want to talk a little bit about the impact of diabetes in Kentucky and something that I call the good, the bad, and the ugly. And I'm going to start with the bad, not because that's the best way to go, but that we're going to save the good for the end. So that's the thing. This is a picture of a infographic that we do have. If anyone is interested in this, this is the top part of that infographic. This is the one about diabetes. There's also one about pre-diabetes, and there's also one about the diabetes prevention program as well. So these are available in the pamphlet library if you'd like to have these little snapshots of information. But this one is about diabetes, and it tells basically at a glance that about 29.1 million people have diabetes. That's about 1 out of every 10 to 11, and about 1 out of 4 still don't know that they have diabetes. And there's also just another way of kind of looking at the diabetes epidemic, and we do call it an epidemic because it does meet the criteria for that. This is a graph that shows from 1980 up to 2011, where we saw the prevalence of diabetes triple during that time period. So it is a problem that is bad but continuing to get worse. And we know that that rise is not steady, it's kind of exponential. So we see that the prevalence of diabetes doubled from 2000 to 2014. So we're up to about 12.5% of folks here in Kentucky. So that's about 1 in every 8 people. And just another couple of ways to look at that. This was part of the, you can get this map and other maps that if you'd like to have anything like these for presentations, etc. There is a website at the bottom of that slide, which is the CDC Diabetes Atlas. So you can kind of query that and you can look for different maps and data and things. And this is one from 2012, and it just shows the different prevalence by county in our state, and red being the highest, again above 11.2. So there's not too much of us that isn't red at this point, but 95 of the 120 counties actually had that rate, that dark red rate above 11.2, which means that puts them in the top 20% of the nation. So we've got a real issue. Another way to look at that, this is just an ad district map, so if you want to look at it that way, the highest prevalence of diabetes tends to be in more the Appalachian area of the state. Not terribly surprising probably, but if you'd like to look at it that way, that's another way to get a picture. But Kentucky also has the 12th highest mortality rate from diabetes. And diabetes is, as we know, it's a bad thing. Kidney failure, blindness, amputations, uncontrolled diabetes can cause obviously all kinds of serious issues, and it is the 7th leading cause of death by disease as well. So it is a very serious disease, and it also costs a tremendous amount of money. This estimate here is from 2012. And it estimates that about $3.85 billion a year, and yes, that is billion with a B, spent on diabetes, and that is both direct and indirect costs. So very, very costly, both in human terms and financial terms as well. And unfortunately, it seems to be getting worse. Our prevalence rates continue to rise, and if things continue to go as they are, about 1 in 3 people would be expected to have diabetes by 2050, according to the CDC. Now, if that wasn't bad enough, that's bad, and there's only so many ways you can say diabetes is bad. It's bad, but it's also ugly, really, really ugly, because the really bad thing is what we've been talking about all this time is just the top of that iceberg. That's the people who have diabetes. If you look at the area below the waterline, those are the folks who have prediabetes, which are people at high risk who are likely to develop diabetes. So, and you can see how much bigger that piece is. We're talking about 86 million people in the country. So it's pretty ugly. Now, there is some good news, though, and I don't want to leave you without good news. A couple of pieces. We do really have some very solid evidence-based interventions done with very good science. We've got really good ability to implement these evidence-based interventions, and we can change some of that. Doesn't mean it's easy to do, but we can do it. And so we're going to talk to you today about a couple of those things. The other piece of news I wanted to mention on the good news side, you all might have seen this in the newsletter or in some of the CDC things that came out, which may confuse you based on what I just said, but I wanted to throw this in here. This is actually a map of incidence. And for those, or a chart rather, but as you know, incidence is new cases of diabetes. We were talking about prevalence, but incidence rates seem to be declining. And this is true both nationally and in Kentucky. So that is really, really good news. So hopefully they watched that trend for the last couple of years before they wanted to say it was real. And now they've decided that, yep, it really seems to be real. Those rates seem to be declining. So that is a piece of really, really good news. So without further ado, I want to turn it over to Janice, who's going to talk about one of those evidence-based interventions, which is the National Diabetes Prevention Program. So this is one of the interventions that is trying to get in front of the diabetes epidemic and try to prevent people from getting diabetes. So Janice is, as Joy mentioned, in Owensboro. So she's not here live, but I will advance her slides for her. And she's, can see her there in Owensboro. I think she's ready. Janice Hale is also a nurse and certified diabetes educator. She sits in Green River, but she's part of our state staff here. And so I'm going to turn it over to her and let her take it away.
Hi, everyone. And I'm so happy for ITV. This made it where I didn't have to spend 6 hours traveling to Frankfurt and back. So this is wonderful to be able to have this technology today. I'm going to spend about the next 15, 20 minutes talking about pre-diabetes and the National Diabetes Prevention Program. Teresa, if you want to go to the next slide, I'll try to remember to tell you that. And as Teresa set the stage, we know, she showed you the iceberg slide, and we know based on some national studies that have been done that we actually have about 1.1 million Kentuckians who have pre-diabetes, but they don't know it. And if you look at our BRFSS data that's on the bottom bullet, you can see that only about 248,000 Kentuckians report that they've been diagnosed with either pre-diabetes or borderline diabetes. Next slide. So what is pre-diabetes? You know, a long time ago when I first started working in diabetes, we said there's no such thing as borderline diabetes. And now here we are looking at pre-diabetes, which is blood sugars that are higher than normal, but they're not quite high enough to diagnose diabetes. So this is what has been shown. If we can intervene when people are in this pre-diabetes range, we can actually delay or prevent type 2 diabetes so that we can be affecting our epidemic and the prevalence of diabetes. So what is pre-diabetes? If you look at this chart, it is a fasting blood sugar between 100 or 100 to 125, a 2-hour postprandial of 140 to 199, or an A1C of 5.7 to 6.4. That's what we are talking about when we say and talk about pre-diabetes. Next slide. And why do we care about pre-diabetes? And a lot of times we used to say, you know, you either have diabetes or you don't, and didn't worry that much about borderline diabetes. But research has now shown that this is something to worry about and something to actually take action. And why is that? It's because 15 to 30% of the people who have pre-diabetes are going to develop type 2 diabetes within 5 years if we don't intervene and do something. And also, we know from research that's been done, 9 out of 10 people who are in this range do not know it, and so we're not taking action to do that interventions. Next slide. So what can we do to help turn the epidemic around? First, we have to find the people who have pre-diabetes. So we need to be doing blood glucose testing and screening. And then we also need to be intervening. And right now, our best research is showing intervening with the National Diabetes Prevention Program is one of the best ways to prevent or delay type 2 diabetes. Next slide. So what is the NDPP? You might see it abbreviated like NDPP or just DPP for Diabetes Prevention Program. It's just referring to the National Diabetes Prevention Program. Next slide. It is the evidence-based program, and this national research that began coming out probably 10 or 15 years ago about the trials that were being done, they have shown that just a modest weight loss, 5 to 7% of a person's body weight if they're overweight, and increasing physical activity up to 150 minutes a week can help prevent or delay type 2 diabetes by 58%. And you might think that in people as they get older it might not be as effective, but the research actually showed it's actually even more effective the older a person is. So by age 60 or over, it had a 71% success rate. Next slide. So what is the Diabetes Prevention Recognition Program? We talked about just DPP, Diabetes Prevention Program. Well, the Recognition Program is just the CDC-led program that was formed to help bring the DPP or prevention program across the country. And it is a way to get recognized, to know that people are doing and following what the research showed when they're presenting or providing the diabetes prevention program, so that we get the best chances of success and helping people get out of that pre-diabetes range back to a normal range. And how is the National Diabetes Prevention Program completed? Next slide. Participants, it's done with a lifestyle coach, and people meet the face-to-face program. They meet in small groups. The groups are usually not over 15 or so people, and it is a year-long lifestyle change program. They meet typically weekly for about 16 weeks, but CDC standards allow actually the first 6 months to complete that 16 sessions, if you will. And then for the next 6 to 8 months, they meet monthly. The small groups meet monthly. And this is the research, at least as it stands right now, that has been proven to actually get like that 58% or 71% reduction or delay in developing type 2 diabetes. So who's eligible? Next slide. Who's eligible to participate in a national diabetes prevention program? Well, first of all the participants that come to a DPP program that's recognized by CDC, they have to be 18 years old, and they have to have a BMI of greater than or equal to 24 or 22 if they're Asian. So everybody in the groups have to meet that criteria. And then at least half of the class has to actually have a blood test sample that's in that pre-diabetes range that we talked about earlier, or they could be diagnosed with gestational diabetes in a previous pregnancy. And it's important to note that both of those, the blood test and or the gestational diabetes, can actually be self-reported. That was changed in the standards beginning in 2015 in the CDC guidelines. Next slide. And then the other half of the class can actually just be high risk, like even if they don't have a blood test that shows they're in that pre-diabetes range, they could be at high risk based on a risk test. And there are a couple different tests that can be done. You can use the CDC pre-diabetes risk test. ADA has a diabetes risk test. It could be a claims-based risk test done by insurance companies, etc. So CDC, when they set up this recognition program, they want, and it doesn't have to be exactly 50-50 on each class session, but overall, when reporting is done to CDC, they want to see at least 50% of participants who have abnormal blood tests in the pre-diabetes range, and the other half can be high risk just based on a risk assessment. Next slide. Okay, what about payment and reimbursement for the National Diabetes Prevention Program? Generally, right now, it's relatively new, and that's what we are all pushing and working for to get coverage for the National Diabetes Prevention Program. And we are so fortunate in our state that our Kentucky Employee Health Plan picked up on this, some of it based on our diabetes report, and that has been done in the 2013 year, 2015 year. It was required by legislation, so that our Department of Insurance, our Department of Medicaid, our health policy and Department for Public Health worked on this report and looked at diabetes within their own areas. And so in that report, they made recommendations, and some of those recommendations had to do with coverage of the National Diabetes Prevention Program. So our Kentucky Employees Health Plan stepped up and began covering this actually in 2014. And so it's been covered now for a couple of years and can be reimbursed. We're one of the largest employers in the state, so it can be reimbursed for all of our Kentucky Employee Health Plan members. There's a new CPT code that also just began in 2016 that is very specific to NDPP, and we're very hopeful that that will help be able to get some processes worked out so that other companies, insurances, and providers can also begin covering the National Diabetes Prevention Program. The national price point set typically for coverage of the year-long program is about $429 for the DPP. Next slide. And you as local health departments, of course, have a tremendous important role in helping get DPP across our state and across our communities. Some of the ways that local health departments are being involved are testing and screening for prediabetes and referring those at high risk into a CDC recognized lifestyle change program, and especially health departments who, since we have coverage for our KEHP members, especially the sites that are doing Humana Vitality, when we get people in that pre-diabetes range, we need to be taking an extra step and looking at where our DPP programs are located and trying to definitely get connections and referrals and make sure those people get enrolled in the year-long DPP programs that are out there. Other ways health departments can be involved is, of course, just raising awareness, the things you do every single day and out in your communities, doing presentations, etc., for your community, making them aware that pre-diabetes is something that we need to be taking action on. And if your community doesn't have a DPP site, health departments can be instrumental. There are many ways that it doesn't have to be the local health department that is the direct provider of the National Diabetes Prevention Program, although it could be. But you could work with your community to figure out who might be the best entity that could carry it on ongoing, and or we could use even more sites. Even if you already have a site in your community, we need DPP being offered much more than it is. It's a tremendous, we have 1.1 million people in that pre-diabetes range, estimated to be in that pre-diabetes range. So we have so much work to do to get enough access, to get enough sites up and rolling. And many of you may have received an email from Teresa and I late yesterday afternoon. We've got some training coming up for the National Diabetes Prevention Program. There is a memorandum of understanding that was attached to that email. So if you or someone you want to work in your community to make it available in a collaborative effort, you may want to look at that and fill out that memorandum of understanding and apply to come to some of the trainings to get some lifestyle coaches trained in your area. And I'll say that the training is for the lifestyle coaches. However, the training, the recognition program recognizes organizations, not individual providers. So it doesn't recognize the coach, it recognizes the organization, and it holds the organization accountable to do the reporting that's required to CDC when those classes, etc., are being done. So there's information that was sent out yesterday that you may want to look for. It was sent out to all local health departments. Next slide. Right now, based on probably just a couple years, I think it was like in 2012, the end of 2012, we only had 2 DPP sites in Kentucky, and those were at basically our YMCAs that were part of the translation research that was done initially with IU University out of Indiana and David Marrero. So our YMCA in Louisville first, and then Lexington came on board too. Those were our first 2 sites. And so just over the last couple of years, we have been able to increase numbers and access to DPP, but it's still a drop in the bucket for what we need to be able to accomplish if we're really going to have an impact on, I always think of that iceberg slide, what's underneath and what's coming if we don't do something to turn our diabetes epidemic around. So right now in Kentucky, if you look at this map, we have 37 organizations in Kentucky covering 60 of our counties. And when we say covering 60 counties, that means that organizations that are CDC recognized organizations have agreed that they will actually come on site into that county to provide a DPP program. But remember, early on I said only about 15 people attend a year-long program, so it takes a lot of effort, and it is a year-long program, and so for 15 people, they'll have an impact. So it's going to take lots of programs and lots of organizations helping to provide and becoming a CDC recognized entity before we're going to be able to make a difference in our epidemic. Next slide. Next slide. And I just wanted to leave you at least with a way that you can actually view a DPP class going on. I put the links on here. If we have time at the end of the presentation, we may actually show this. They're just like 5-minute video clips. There's a couple of them. There's one on the KET website, and then there's actually CDC uses Kentucky on their CDC national site. They use our videotape that they did at our Louisville Y years ago. So if we have time, we'll show it, and if not, the link is on there where you can come back and maybe watch that if you want to see more about how the class itself is conducted. Okay, I'll turn it over to Ken DeCoste, who's going to talk about our diabetes DSME evidence-based interventions. Thank you.
Thanks, Janice. And many of you may know Kim she's been around a little while, just like the rest of us. We did our little math today that collectively we're been here almost 90 years. So we were, of course, 2 when we started. But anyway, Kim has a lot of great experience with diabetes self-management education, and so we'll turn it over to you.
Thanks, Teresa. So Teresa presented the bad and the ugly, and then Janice led us into some of the good things we can do. But there's still a problem. Janice presented what we're going to do about those folks that are underneath the waterline with that iceberg picture, and I'm going to talk about what we're doing for those that are above. So it's great if we can prevent, but we can't always. So I'm going to talk about evidence-based interventions related to diabetes and diabetes self-management education. And as you all know, those long-term complications that Teresa mentioned that are so devastating to those folks, what can we do about it? Well, the great news is that there is something we can do about it, and there is evidence that indicates that DSME works, or diabetes self-management education. Let's see here. Okay, so what is diabetes self-management education? What we do as diabetes educators is we help people through facilitating the knowledge, the skill, and the ability necessary for pre-diabetes and diabetes self-care. If you do a little estimate of the amount of time that a person is actually with their healthcare provider, what we know is a person with diabetes is actually doing self-care. I think it adds up to about 99.8% of the time. So if we don't have folks that know how to take care of themselves, then that leaves a problem. I always get a little bit tickled when I ask a patient, well, what do you do, to take care of your diabetes? Oh, now my doctor takes care of that for me. And then you kind of do that and you're like, okay, you must have a really good provider that's with you all the time. So what we do in this process is we incorporate the needs, goals, and life experiences of the person with diabetes or prediabetes, and it's guided by evidence-based standards. The overall objectives of DSME are to help to support informed decision-making, self-care behaviors, problem solving, and active collaboration with the healthcare team to improve clinical outcomes, health status, and very importantly for all of us, quality of life. With diabetes self-management education, we focus on 7 different self-care behaviors, and these are called the American Association of Diabetes Educators, or the AADE-7. Healthy eating, being active, monitoring, taking our medication, problem solving, healthy coping, and then reducing the risks. So the problem solving is typically related to short-term complications like high and low blood sugars or sick days, or maybe problem solving related to what do I do when I'm going to travel someplace but I have diabetes and I need to take this away from my usual routine. So that's what we tend to help people do as diabetes educators. The evidence comes with accredited or recognized programs providing this diabetes self-management education. And what we know is an accreditation or a recognition is required for reimbursement from Medicare. And as you all know, with reimbursement, Medicare tends to set the standard for what's paid for or what's not paid for. There are 2 organizations that have the authority through CMS to provide this accreditation or recognition. One of them is American Diabetes Association. They offer recognized programs. And the American Association of Diabetes Educators offers an accredited program. These require a G billing code for individual or group education. So why recognition or accreditation is very important? We know that ensures that you're offering that patient quality care, that you're meeting the standards for diabetes self-management education. It also may offer an opportunity to facilitate reimbursement. So we know that. And then it also is kind of a credibility thing. It lets the providers and the patients know that you have a quality offering that you are providing. The national standards, they're updated every few years. I think there's a group working on the latest update right now. So these are called the National Standards for Diabetes Self-Management Education. And in 2012, they added support to it. Because we know that if you all are sitting here with me as a group, and I talk to you about diabetes education, and you're all pumped up today, and you leave, and you're so ready to conquer the world, and then you get a month down the road, and life starts to interfere again. So we need that ongoing support. And we know diabetes education itself is a little bit dose response. So we know that you can actually get more improvement in outcomes with that ongoing support. So that's why we're very glad that they added that. But the national standards, when you're applying for accreditation or recognition, that signifies that you are meeting these national standards for diabetes self-management education and support. Diabetes self-management education is evidence-based that it does improve outcomes. And I really like this outcome continuum here. So you look and the folks come to their diabetes class or they come to their individual intervention. Mostly it's done by groups, let me say that. And CMS doesn't want to pay for individual unless it's something kind of specific like insulin instruction or unless you have a person who has a disability that might require that. One group that I have found, like a hearing impaired person, we needed to do individual because that was, we asked them if they wanted us to get a translator, but they chose the individual over that. And so that is something that the payers will approve in that way. So you come primarily to a group, and there's where that learning takes place. So we spend about 8 hours. And some of you may be familiar with our diabetes self-management education curriculum. We're getting ready to launch next week at our local health department call our 2016 update by a new format on Train to make it more easily accessible to folks. So that's the curriculum that people within the health departments use to provide this education. We've been using it for a long time and updating it since 2000, I think is when we first created that. So this learning takes place. And then from that, we encourage a patient or a participant to set a self-care behavior change goal. It may be as simple as I will walk around the block 3 days a week, every week, starting next Monday. So that's the behavior change. Then we'll look at the clinical indicators. We would ask for A1C or outcomes, maybe blood pressure changes related to what it is that they're doing. So how well are you doing meeting your behavior change goal? And then we have other goals that we look at based upon specific programs. So we'll look at those clinical indicators. And then from that, you'll have an improved health status. And I love in my accredited program, this was a person, he was actually a young guy. I went to high school with him. So anyway, he sent back in his evaluation, and on that he said, before I came to classes, I didn't know what to eat. Now I'm counting my carbohydrates. So there was his learning, there was his behavior change. When I came to class, my A1C was 11%. I went to my doctor last week, and it's now 6.2. So there's that clinical indicator. The improved health status, he said, I feel better than I have in years. So that evaluation that we did went across that whole outcome continuum, and it indicated a real positive outcome, but it also decreased his risk of some of those long-term complications by, well, if you're looking at an eye complication, by close to 70%. So that's huge. That makes it worth getting that A1C down. So that's how we work with our patients about those kind of things. And the other great news is we know that DSME improves cost. So if you look at DSME provided within an accredited or recognized program, so it's not only clinically beneficial with those A1C and those other outcome improvements, but it's cost effective. And I've already mentioned that it's kind of dose response. The repeated encounters enhance the benefits. So this is from an actuarial study published in 2009, looking at claims from both a Medicare and a commercial population. So it demonstrated that DSME showed a 5.7% less cost per month. So $54.26 per month, and then in the Medicare, 14%. So these were primarily related to lower cost, and you can guess what it was related, how you got those lower costs. Hospitalization, so acute care. And that's where the biggest expenses come from. So primary care and prevention cost, you might look at those, and they actually could be a little higher, right? Because if a person is actually taking their medicine, it's going to cost more to refill their prescriptions more. So, but you look at the long term and that overall cost savings, and it was huge. And we think about the number, I don't have the exact number of Medicare beneficiaries in our country that actually have diabetes, but if you think about $140-something per month cost savings, that's huge. We might have a solution for the budget issues if everyone would listen to us. this is a little bit sad, and I don't have a more current CDC number on this. We're expecting it kind of any day. It's this time of year that we usually get it. So the people with diabetes in Kentucky receiving an encounter with an accredited or recognized DSME program was approximately 4% of people who have diabetes. Now, because I've worked with the Diabetes Prevention and Control Program for a very long time, I know that that's related to the accredited or recognized programs. What I'm hoping is people are getting other interventions that are actually helping them with that, but the evidence goes with this accredited or recognized program. So some of it could potentially be related to difficulty with access. Some could be related to difficulty with paying, because the sad thing is that even if you have Medicare or if you have an insurance, which our state law says it has to pay for it, for diabetes education, you may still have a really high copay. And, you know, are you going to buy your groceries, or are you going to spend $300 copay to go to your diabetes classes? So there's some actually movement on a national level to try to get people to take away that cost-sharing piece of DSME, because it is so evidence-based that it actually helps. So if somebody asks you, you might tell them you're in support of that as well. So anyway, so we want to increase that. Another thing, though, is we know that right now in Kentucky, we have 53 different accredited or recognized programs. We have 47 counties which actually have an accredited or recognized program, though. So you have some of the counties have, you know, a lot more in that, which you would expect, like Louisville, Jefferson needs a lot more than a smaller county. But we don't have enough. And so what is going on that we're doing about that? Well, January 15th of this year, Kentucky Diabetes Prevention and Control Program became an accredited program. So we are doing an umbrella diabetes accreditation program where we're the accrediting organization here at the state office, but we are pulling in health departments across the state, targeting some of those underserved areas where there's less access. So the name of the program, and this is some of our pilot sites, actually are the ones who named this, Healthy Living with Diabetes for the Kentucky Department for Public Health. If you can see on the map, the places that have the little Kentucky Diabetes Control Program logo are the places where we have different sites. Our pilot sites were Pennyroyal District, Lincoln Trail, Louisville Jeff, and let's see, I'm having a mental block, and Lexington Fayette. Okay, so those were our 4 pilot sites. Since that time, we have trained 5 additional sites. The Northern Kentucky, Kentucky River. We've also trained Purchase. We have trained, I should have had this in front of me. Anyway, they're all on here. Bell County, Kentucky River, Floyd County. I've already showed you Fayette, Lincoln Trail, Pennyroyal, Purchase. But we have 9 that are actually collecting data and outcomes related to their diabetes self-management education. We have another training planned for April where we'll pull 5 more and maybe even a few more than that. So if that's something you're interested in, please reach out and chat with us about that. You can talk to me or Becky Thompson related to that. But we're very excited about this. And you can see a little star by Pennyroyal District. That is the one site that has gone through their whole kind of cycle, and they are our only accredited site at this time. But the second that Fayette County's done, then we'll pull them in and all of the other sites that I was talking about. So these are the ones that are in the queue for our April 18th training. And then Becky and I have about 3 other sites that we're going to be speaking with that may come in April, or possibly not until the next fiscal year. Another requirement for our accredited programs is that they have at least one licensed diabetes educator working in their program. In 2011, Kentucky became the first state to license diabetes educators. And if you think about it, why is something like licensure important? Well, it looks at the health professionals. They're all health professionals. This is for consumer protection. What you might find is someone there that would say they're a diabetes educator, and they might be, I guess they might not have any license, no professional really criteria for that. I went in a little store one time, and actually I had a clerk in that store kind of try to teach me about how to eat if I had diabetes. You know, she started pointing me to things on the shelf and stuff. So it would try to help prevent those types of things from happening. So I encourage you as a health department administrator, support your staff, your licensed staff, a nurse or a dietitian, in becoming a licensed diabetes educator. And this is something that, you know, if you choose, would be appropriate use even of your 809 funds. So this offers consumer protection, quality guidelines for the profession. It'll give us increased access. We have 270 something certified diabetes educators in Kentucky. We have almost 500 licensed diabetes educators. And I think one really important part of that is those people are required to have 15 hours of dedicated diabetes continuing education every year. So once again, back to reimbursement. State law requires coverage of diabetes education. There's also employers at work sites that might make that be a covered service. Medicare offers the DSMT benefit. I've mostly said DSME. Medicare doesn't pay for education, they pay for training. So that's why you might see DSME/T, and it's just a logistic, really. It requires a physician referral, covers recognized and accredited programs only, and patients will have a copay. Medicare covers the $80, and then it's allowed to the adjusted rate. The patient pays that $20. So there's up to 10 hours per year. So there's some little glitches on this, and you would work with the diabetes educators in your community to help make sure that the patient will get their service paid for related to how the benefit is rolled out. Medicaid, it is on the preventive fee schedule for health departments, and so it is a covered service for all MCOs, but each one has their own protocol. There's no guidelines that say what has to be covered and how much. So like I mentioned, we have 8 hours of DSME. They may only pay for 2. So we don't know the number of visits per year. The reimbursement amounts are different, and some of them have prior approval and some do not. So what's here for you? What are the next steps? Explore where the DPP and DSME programs are located in your community and refer to them. On this last slide, I think we have the link to the Diabetes Resource Directory. If you're not familiar with that, it's a wonderful tool. You would go to that site. You would pull up that resource directory. You can filter it by your county and adjacent counties as well. That would show where an accredited program is. That would show where a DPP program is, or other diabetes self-management support services. So if none are available, then consider becoming a site, just as Janice said. You would consider that. Or talk to another partner. One of the dietitians we work with in one of the areas, she wasn't positioned to do it in her small health department, but there was a wellness center. It was one conversation with them. They signed on to do an online training the next day, and now they're already, you know, a week later they were listed as a pending site on the CDC site. So that's how fast it can happen. Sometimes it's just asking. Clinic and community services, as Janice mentioned, assess for risks for prediabetes. If high-risk, counsel and refer them to a DPP site. And get feedback from the providers and provide follow-up and support and encouragement for continued participation. When we provide these services, sometimes we don't reach out to the providers and let them know that their patient participated in that, and that's a very good, kind of a referral growth mechanism for us, is when we complete that loop. Counsel and refer patients with diabetes to an accredited or recognized program, get feedback from those providers as well, and refer the patients for diabetes self-management support opportunities. The resource directory also has all of those opportunities on it. If the extension office offers a healthy living with diabetes, cooking class or whatever, dining with diabetes, those will be listed there. And support your local health department staff in becoming a licensed diabetes educator. It requires that they be a medical professional, they would have a supervisor, and they would start to get their accrued experience with that as a licensed diabetes educator apprentice. So your call to action: raise awareness of diabetes prevention and control, share information about the DPP and DSME, help patients access the resources, work with local businesses, insurance carriers, the policymakers to encourage the coverage for these things, and promote those efforts to make these things covered benefits under your public and your private resources and payers. So that's what we have, and then we would open it up for questions. And if there are not questions, we'll jump back to Janice's video here in a second. Questions?
One thing I did want to point out, Kim, is, and to all the health departments, all of the work that you all have been doing over the last 2 years that we've been doing community diabetes assessments. So your staff have really been instrumental in making that Kentucky Diabetes Resource Directory what it is becoming. It really is, becoming current and has what's available related to diabetes, and I think that all goes back to the local health departments and those assessments you're doing. You all also are collecting, a piece of that assessment is collecting data from your county. It's county by county assessments, and you're collecting data on numbers of people coming through diabetes education and or the DPP programs. So that also gives us a snapshot statewide, what's going on that we've never had before in that way, and it also can give you, your local community, a snapshot of what's going on related to these 2 evidence-based recommendations for diabetes, to show if your community as a whole needs to work to get those better where we're living.
Thanks, Janice. Another thing I wanted to add is we also have 3 other health departments who have their own accreditation. That's the Lake Cumberland, Northern Kentucky, and Madison. And so if you were not wanting to come under the umbrella of the state healthy living program, we would encourage you to become an accredited site on your own. What we've done, there's a fair amount of paperwork, and we tried to take that burden away. Another thing is a lot of sites offer classes, and they use our curriculum, and they're not part of the accredited program, and that's okay, and we still encourage that, and we still support those groups in providing, those local health departments in providing those classes in their community, and we like to help support individuals if they're not comfortable with that, or if they have new staff. We have a training that people go through to become more confident in that, and we can actually come out and make some site visits to your facility, to your agency, if need be, and help you get that going if that's something that's not being provided there right now. Okay. Do you want us?
You want? Yeah. Do
you want us to try the video?
Yeah,
we will try that. Yes. Okay. Let's see.
We'll try that link, and there.
Oh, whoops! I went one too far.
There she was. Yeah.
Okay. Let's see if we can get this to work. Let's see. Yeah. And I think our IT person has slipped out,
Yeah.
but we'll give it a try. He said it may or it may not, no guarantees. Let's see. There it is.
It's looking encouraging.
It's looking very encouraging. And I like this too, because as Janice mentioned, this happened in Louisville, so it's not like the people sound any different than us. They've got the right accents and everything.
All right, back again, week 13 of our diabetes prevention program. Physical activity, yay!
The classes that are part of the National Diabetes Prevention
Can you hear that,
Program
Janice?
work because they have been studied and tested. We have known for some time now, based on really well-done research studies, that you can prevent or postpone type 2 diabetes. This is the opportunity for us to implement those findings in a way that the population can experience it.
Tim, looking at how far you've come, what else is out there? Where else do you want to go? In their core 16 weeks of this program, participant will come in and meet once a week with their facilitator and their small group. We'll sit down and we'll discuss one of our 16 lifestyle topics for that day.
I've been pre-diabetic for over 2.5 years, and I just kind of ignored it because that word pre was there. I knew that my blood sugar was high. I would watch my diet a little bit, and then I would stop. But I didn't do anything consistently on a consistent basis.
There's an issue with the patients not realizing the problem is as bad as it is or as bad as it may become.
The first few weeks of the program, we're talking all about fat gram intake, behavior modification, your level of activity and how physically active that you are during the day, and stress management.
Stress management is a very important piece when it comes to lifestyle change. It affects people's eating, it affects people's physical activity, it affects everything that has to do with lifestyle change.
A lot of people think you have to have machines and tracks and things like that to constitute exercise. But what we look at in the class is how active are you really throughout the day?
I like to walk early in the morning. It gets your day started, and it's a good little power walk. And it's free. It doesn't cost anything to walk here. 6, 7. Initially, I was in denial about the fact that there's a higher percentage of African Americans affected by diabetes than other ethnic groups. But all around me, friends, family, church members, I was seeing younger and younger people affected by the disease. One of the things that we were required to do was to set a goal of weight loss, set a nutritional goal, because we established what our fat gram content had to be for the day. We were to set in our books exactly how many minutes we were going to exercise every day.
The real success is that people are working together to try to find the solutions and to support each other.
Without the class, I would have never done this on my own because I had tried. I had done every single thing out there that I could think of.
My hope for this program is that many physicians across our community will use this resource as their first line of defense against type 2 diabetes. That's what our program is here for.
This is really the example of what we wish would happen in many fronts, is that the government, the private sector, and the community sector would really join forces and come together to solve these problems.
My patients love the idea of being able to have a program to be healthier going forward. My patients
Well, they're like, what is
really love that. They're surprised that they can actually get older and be on fewer medications.
I am so excited because I went to the doctor last week. All of my numbers were down, and I am officially no longer pre-diabetic.
There are almost 80 million people that have prediabetes. My dream is that in the next few years, it will be easy for people to get access to this program. And ultimately, we will be able to say fewer people are developing type 2 diabetes.
Thank you all. And you got the contact list. If you need to reach any of us, please reach out. Thank you.
Thank you, Tim and Teresa and Janice and Owensboro. We appreciate the timely presentation on the burden of diabetes in Kentucky, the training opportunities and evidence-based strategies to help us improve the diabetes outcome. So thank you. Katie, if you'll want to go ahead and come on up, we'll switch out the presentations here. Next, I'd like to introduce Katie Myatt, who's an epidemiologist, with the Reportable Disease Branch in our Division of Epidemiology and Health Planning. So she's going to speak today about Legionnaire's disease and Pontiac fever. This presentation will count for 1.0 ERRT credits. Is that correct, Katie? So if you'd like to come on up, and we'll be glad to let you go ahead and start. Your presentation's all ready for you, and then your handouts are there too, don't forget. So yeah.
There's a clock, so
okay.
that's all I was worried about. So just a little bit of background on me and this presentation. I started out as a regional epi at North Central District Health Department and then moved to Lexington Vet. So I kind of took the perspective of investigations on the local level, so hopefully that will be most helpful to you. So we're going to start out with, of course, some information on Legionella, the history of Legionnaire's disease and Pontiac fever, biology of the organism, of course, epi characteristics and clinical characteristics. And then I'm going to do some demonstrations on entering a case in NEDS and some questions that we get when we do an investigation in healthcare facilities. So I thought this was really interesting. The first outbreak of Pontiac fever was documented in 1968, and ironically enough, it occurred in individuals who worked at a local health department in Pontiac, Michigan, or visited a local health department in Pontiac, Michigan. So the illness was fairly mild. No pneumonia was observed with the cases. There were no deaths, but investigators were never able to figure out what the organism was. They did an epi curve and thought that it might be airborne transmission, and they also did some animal testing on guinea pigs and noticed that when the guinea pigs were exposed to the water from an air conditioning unit in Pontiac, that they got sick. And then when they sterilized that water or autoclaved the water, the guinea pigs didn't get sick. But the years went on with no real identification of what the organism was. So then we fast forward 8 years to what Time Magazine called the Philadelphia Killer. Pennsylvania had a convention for the state for American Legion members in July of 1976, and after these people went home, people started getting sick. I think somebody's mic is not muted.
There's an open mic out in the field. If you wouldn't mind to check your mic, please. Somebody who's just joined us has an open mic. Thank you.
So, identification of this outbreak occurred in like 3 separate areas of the community in the state. Time Magazine recognized Dr. Ernest Campbell as being the first to see that he had a couple of cases in his patients that had the similar symptoms, and they had all 3 gone to this convention in Philadelphia. Around the same time, attendees and families of attendees of this convention were calling the state American Legion officials, letting them know that at least 9 people had developed similar symptoms and 1 individual had died. And then on the state level, the Pennsylvania Department of Health was getting calls about similar symptoms in these American Legion members. And that opened up grounds for a much larger epi investigation. And it prompted CDC to bring in EIS officers who got on the ground and interviewed these, I think they were all men, but don't quote me on that. And bedside at the hospital type interviews, so very in-depth. They couldn't, at this time, early in the investigation, couldn't determine the organism that was causing this. There were speculations behind maybe it being swine flu and other types of influenza, but they didn't have an organism. So 182 cases of respiratory illness were identified, 29 individuals died, and they named it appropriately Legionnaire's disease because of who it was affecting. And so we moved forward another 5 months, and someone finally identified what was causing all these individuals to get sick. And on guinea pigs, again, I'm not sure why we have to hurt the poor guinea pigs, but so Joseph McDade was the first to isolate Legionella pneumophila, and he did that by inoculating guinea pigs with tissues of the individuals that were sick. And then in previous attempts to isolate, they had used antibiotics during the procedure and obviously weren't able to isolate the bacteria. McDade changed his procedure, got rid of the antibiotics, and lo and behold, found Legionella pneumophila. So after he recognized or isolated the organism, retrospectively, we saw several outbreaks, including the Pontiac fever outbreak in the 60s. So, what is Legionella? It is a gram-negative bacillus, and it's an aerobic organism, and since its identification in 1976, we have about 60 species of Legionella identified. About 70 to 92% of infections by Legionella occur due to Legionella pneumophila serogroup 1. So that's our main causative agent. It does like warm environments, so you'll see a summer type or spring temporality with your cases. It replicates best between 77 and 113 degrees Fahrenheit, but it has been found to survive in harsher conditions. So that's just an average range. It's in our natural freshwater environment, so it occurs around us, and we expose ourselves to it in the natural environment regularly. So, how does it do this? Well, Legionella prefers to infect protozoa and amoeba, which are single-celled organisms, and it does this because if it infects those organisms, then the amoeba and protozoa will protect it from harsh environments and provide it with food. So, why not? That being the case in its natural host, our alveolar macrophages look very similar to protozoa. So when we come in contact with Legionella bacteria, it thinks it's its natural host and it infects us. On the picture, you'll see a really good electron micrograph of the green Legionella bacteria getting ingested by an amoeba, and it's got its little, I don't really know what to call that. It's reaching out and grabbing it is what I call it. But so just a quick slide on the life cycle in a macrophage. Legionella infects the cell, and within 4 to 6 hours, it's replicating within the cytoplasm of the macrophage, and within 14 hours, it's replicated enough to where it's going to break out of the cell and infect other cells. So I titled the presentation, Legionnaire's disease and Pontiac fever, and we looked at the fact that Legionella causes Pontiac fever and Legionnaire's disease, but it's complicated, I think, also by the fact that the two conditions are clinically and in many cases epidemiologically distinct. So Legionnaire's disease is a much more severe illness, always accompanied by pneumonia. Symptoms include cough, muscle ache, shortness of breath, headache, and a high fever. And Pontiac fever is a much more mild illness, flu-like illness with fevers, chills, and malaise, and is not accompanied by pneumonia. As far as the epi characteristics, the incubation period for Legionnaire's disease is longer, 2 to 10 days. Duration of illness is longer, it occurring for weeks in many cases. Hospitalization is very common. The mortality rate is 5 to 30%, and the attack rate is fairly low at less than 5%. Pontiac fever, shorter incubation period, 24 to 72 hours. Duration is much shorter, 2 to 5 days. Mortality and hospitalizations are uncommon, and the attack rate is much higher at greater than 90%. So, Legionnaire's and Pontiac fever is transmitted by water, right? Not person to person. So, in exposures, there has been some sort of mechanism to aerosolize the water. We breathe it in, and that's when we get sick. In rare cases, people have been seen to aspirate on drinking water and get sick that way, but like I said, it's fairly rare. And there are several risk factors that go into Legionnaire's disease. Age, smoking, chronic heart and lung disease, being immunocompromised, diabetes, malignancies, renal disease, and alcohol abuse. And I just put a quick number in there for the incidence of hospitalized cases of Legionnaire's disease, and that's 8,000 to 18,000 cases a year in the U.S., but that's likely underreported. So take that with a grain of salt, if you will. And then lastly, Legionella pneumophila has been shown to infect extrapulmonary sites, so wounds, bones, bone marrow, and joints, and several others. So how do we know we have Legionnaire's or Pontiac fever? For Legionnaire's disease, if you have pneumonia, it's likely going to require chest x-ray to diagnose. For testing for infection, we have culture, which is the gold standard, urinary antigen test, which is the most common, and then PCR and antibody and serology that we can do as well. The urinary antigen test will only detect serogroup 1, so it is a very good test. It's a confirmatory test, but it is limited by the fact that it's only that most common serogroup. There is treatment for Legionella. The American Academy of Pediatrics Red Book, which is where I got this from, recommends azithromycin for 5 to 10 days for most people. If you need an alternative, levofloxacin, doxycycline, or trimethoprim, sulfamethoxazole. Excuse me. So, we breathe in this contaminated water. How is it getting in? What type of environmental exposures are causing us to breathe in this water? Well, if Legionella is really good at grouping itself together if you have a man-made water system. So in the plumbing and storage tanks, hot water heaters, cooling towers, we set up the environment for Legionella to group together. When it groups together like that, it increases in concentration. And then when we aerosolize that water, like in a shower or hot tub or wherever else, we expose ourselves to enough to get sick. And we talk a lot during these investigations about hotels and resorts and cruise trips. Did you travel somewhere? Did you sleep over somewhere? Why do we do that? Well, hotels and cruise ships have very complex water systems, and they also have more of a likelihood of having aerosol generating devices. And that just promotes a very great environment for people to expose themselves. And then not only have we created this great environment, but we're also exposing lots and lots of people every day as we filter in and out of these environments. So I really like this picture graph because it kind of combines all the way Legionella gets into our environment and gets sick. So you start out at the top left, and you've got Legionella in the natural environment. We bring it into our man-made environment. We give it a chance to amplify in our systems, and then we aerosolize it and expose ourselves. So most of the individuals exposed are going to have no infection, or they're going to have Pontiac fever, and then a smaller percentage are going to get Legionnaire's disease and be hospitalized. So what do we do? How do we prevent cases? In hospitals, I would get questions on what they should do as far as isolation. Well, it's not a person-to-person spread, so standard precautions are sufficient for hospitalized patients. And if you need to disinfect or sterilize your water, that is, you have the potential to do that with several different means. To prevent disinfection from needing to occur, keep your hot water hot and your cold water cold. So if you're able to, I know OIG has regulations on how hot water in long-term care can be. If you can keep it at 140 degrees Fahrenheit or greater, that's great. Otherwise, keep it as hot as you can by regulation. Cold water, 68 degrees Fahrenheit or less. And then if you have a boil water advisory, you can also superheat your water so that you emergency disinfect. And there are point-of-use filters and shock chlorination available as well. So now let's move on to cases in Kentucky. When you're reporting a case of Legionnaire's disease, we use the Nationally Notifiable Disease Surveillance System case definition. And the website is in this PowerPoint for you to refer back to. You can use this search box at the bottom to search for other conditions, but the link will take you straight to the Legionella case definition. So if we look through it, you'll see down at the bottom you have two possibilities. You could have a suspected case or a confirmed case. And both of those case definitions are based on clinical criteria and laboratory criteria. So when you get a case that's clinically compatible, which is the easy part, take your lab reports back up to this section and determine, do you have a suspect case because you've got seroconversion with an antibody test, or you've got DFA stains, or you've got a PCR, then you've got a suspect case. If you've got an antigen test, you've got seroconversion of 4-fold or greater rise in antibody titer, or you have a culture, then you have a confirmed case. Okay. So when we get these case reports in at the local health department, what do we need to do with them? Well, first, you need to collect information. It's not like, usually when we would get cases at the local health department, we didn't get everything we needed to meet our case definition. So go back to your provider, your infection control nurse, and ask for more. History and physicals are really useful in hospitalized patients, admission and discharge summaries, and then any additional lab tests you need to meet that case definition, you'll have to ask for. It's also a good idea to get impressions from chest x-rays if you have Legionnaire's, case of Legionnaire's, just so that you have it on file and you can note it in our surveillance system. Then, like I said, we're going to compare our medical records on this particular case to the case definition and see if we have enough to meet a suspect or confirmed case. And then, as long as the patient has been notified by their provider first, call the patient and do an interview. And we do this through the CDC's Legionellosis case report form. And I want to go through that specifically because while it's pretty straightforward, there are some nuances with the form that would be helpful to talk through. So we're just going to go through it line by line. Maybe. we go. Okay. And I think this went out over email, correct? Okay. So you all have this in front of you. And if you have questions, you can always get in touch with Reportable Disease and we can get it to you as well. But so we want to start out with the State Health Department case ID number. And that is your NEDS case ID number. So every time you enter a case in NEDS, you get a six-digit number. Put that in that box. The rest of the boxes from 2 through 9 are pretty self-explanatory. Patient demographics are not, nothing needs to be explained with that one. But then when we get to box 10, we've got a choice. Is it Legionnaire's disease? Is it Pontiac fever? Or do we have an extrapulmonary infection somewhere? Do we need to check that box? You can fill this as an electronic copy if you want, or you can handwrite it. It's whatever you feel more comfortable with. But if you do decide to electronically fill this, make sure you come over here for Legionnaire's disease and circle how the pneumonia was diagnosed. Is it clinically diagnosed or is it an X-ray? Moving on to box 11, when did the patient's symptoms start? Not when did they get admitted to the hospital, not when were they tested, but when did the symptoms start? And then, was the patient hospitalized, yes or no? And then the date of admission. And these are some things you'll find that when you're interviewing the patient, they may know some of it, they may not. You might have to cross-reference your interview with the patient with the medical records to get, a complete form. Moving on to box 15, one of the things that for some reason this form defaults to is that this box right here is checked, yes. So if you didn't have a patient that stayed away from home in the 10 days prior to symptom onset, make sure you either uncheck that box before you print it or check it, keep it checked if they did stay somewhere else. And here's where we get into, and then you'll need to name the accommodation specifically. When I did interviews in the past, if I could get them to tell me the name of the place and generally where it was, I'd probably go back and Google the address just to find out specifically where it was. It's probably not something that your patient's going to know for sure of. Number 16, in the 10 days before onset, did you spend time near or in a whirlpool spa? Pretty clear, but we want to make sure that we're indicating where the potential exposures occurred for the patient. So, whirlpool spa equals aerosolized water that could be infected, so we want to know about that. Respiratory equipment, obviously another thing that you want to pay attention to. I think we have sometimes we're more likely, especially at home, to fill our devices with tap water than sterilized water, so respiratory equipment can be a source of exposure for cases. And then we've got healthcare settings. So healthcare settings, we have an increased number of individuals that are likely at risk. If the exposure is occurring in a healthcare facility, we want to know that and we want to follow up with them so we can prevent future cases. So this is an important box as well. Same questions for assisted living facilities. They're kept separate. So long-term care, hospitals, skilled nursing facilities, clinics go here. Long-term care, assisted living facilities go here. And then lastly, we have boxes for your testing. So was the case confirmed or suspect based on that case definition? Did you have a urine antigen test? Did you have a culture? Did you have a fourfold rise in antibody titers? Or did you have the other tests? Okay. And I'll give everybody a chance to ask questions about forms and NEDS entry after we're done. So next, I want to go over entering a case in NEDS. So NEDS is lovely, but it has some, the investigations aren't always exactly the fields aren't exactly what you need for every disease, so you need to know which fields to fill in. And sometimes filling out those lab portions of NEDS can be kind of tricky. So we're going to, since we have some time, we are going to go over that. And I'm just going to the NEDS training site. If you would like to, and this is great because you can make up whoever you want, and you can play around with all the possible combinations of entering a case. And if you would like to practice with NEDS entry, then get in touch with your regional epi, and they can get you this login information and help you with NEDS entry. So I went ahead and created the patient just as good practice when entering in NEDS. Always search for the person that you're getting ready to enter. It's with the system, it's possible that that somebody has already created the patient. You don't want to duplicate that entry. You want to fill in the investigation underneath the patient that's already created. So search for the patient by the first name, last name. And here's the patient that I created. And I'm not going to go through those demographics. If you need help going through entering a case, creating a case in NEDS, again, get in touch with your regional epi or me, and we can walk you through it. So this is my patient, Miss Legionella pneumophila. Very clever, thank you. She was born in June 1940. And we want to add, we have a lab report for her that says she has a urine antigen test that's positive. So you go under the events tab, go to add new, and we're going to start entering this case. Okay, so starting out, I like to point this out because the reporting facility will automatically default to the agency that the person entering this data works in. So if you in the local health department are entering this, then it's going to say local health department and address. So you want to change this to the name of the lab that ran the test. So I'm just going to choose, the test site doesn't have as many laboratories available as production site for NEDS, so I'm just going to pull up a hospital because they're likely to have run the antigen test. LabCorp and Quest run quite a bit too, correct, Stacey? Okay. So we filled out our reporting facility, that's the name of the lab. Ordering facility, if you have that. Ordering provider, if you have that. And then you'll have to use these search boxes. Following that, the program area is respiratory invasive. Jurisdiction is, I think, defaults to the county of residence. So if your demographics for your patient aren't correct, then you'll need to make sure the jurisdiction is changed. The lab report date is the date of the result. Not the date of collection or when the lab received it, but the date of the result. So that can be in several different places on those lab reports, and usually received and collected is well documented, so you'll just need to look for another date. We're going to go with today's date. The date we got it that we received the lab report in public health. In a perfect world, we would get it the same day. I'm not sure that'll happen. Ordered test is going to be the name of the test that they ran. So the best way to find what you're looking for is to go to that search box and type in just a general term. So we're looking for tests associated with Legionella. I'm just going to type in Legionella, and it comes up with all the different options. If we have a Legionella antigen test, I'm going to choose this and then go through the rest of the boxes. Find the specimen site or source, which is urine. And then here's where you want to put in the date collected. So let me just do this. 2 days ago. Then we want to go to the results of tests. So what were the test results? We have Legionella pneumophila antigen. And then if you have something, it might indicate it was positive or detected, whichever the lab report says. And then if you have additional results on the paper lab report that you want to add in, but there's no drop-down box for that, fill it in right here. So if it says serogroup 1, just write it down. And then hit add test result. And now we've entered, essentially, we've recreated the paper lab report. So we know we need to do an investigation. The next thing we want to hit is submit and create an investigation. Find Legionella, hit submit. And this gives us the fields for our investigation. So under case info, I'm just going to notate some of the fields that we need when we're reporting these cases to CDC. So it's always good to have a start date. We started the investigation today. That's good for tracking purposes. Not necessarily a requirement, but good to have information. Did a report, earliest date reported to county, all good tracking information, but not necessarily essential to the investigation. Choose who notified you. In most cases, it's a hospital or a laboratory. And then we get to the things that we really need. Was the patient hospitalized? Yes. Where? You can search for it. If the hospital where the patient has been hospitalized is not included in the NED system, then you can put it in the comments, but then shoot us an email because we can always add more providers and hospitals to the NED system, and it'll only make our system better. So I think to do that, you just need the address and the name of the facility. So you can email that to me or a couple of people at Reportable Disease. You can contact your regional epi. They know how to do it as well. Admission date, of course, very important. We're going to go, I think that's when I said the patient was collected, specimen was collected. Were they discharged, yes or no? And this field will populate for you. Diagnosis date, not as important as the illness onset date. If you have the diagnosis date, that's great, but you definitely want the illness onset date because that is how we're going to go back and look for exposures. So, let's say she started on the 15th. Was the patient pregnant? No. Did the patient die? Yes or no? Very important. Date of death. Yeah. And then any other information. Because, like I said, this investigation in NEDS is not specifically built just for Legionella. There are several pieces of information that we need to have. So the best thing to do for that is to go into this general comments field and start filling out things. And in the PowerPoint, I've listed what those things are and where they should go. But just for the purposes of the presentation, was the pneumonia diagnosed by X-ray or was it clinically diagnosed? What were the patient's symptoms? Because in this investigation, the only two symptoms you really have are diarrhea and temperature. Not enough to meet a definition for Legionella. If you have admitting and discharge diagnoses, those are important as well. And then travel history, of course, is very important. Did the person go anywhere in the 10 days before symptoms onset and spend the night away from home? Then we're going to submit. That saves our investigation. And if you have all the required information at this point, then you would create a notification and that sends it to Frankfurt so that Stacy Davidson can check it over, make sure everything is included, and send it on to CDC for the counts. So let me open it up to questions on those two things because we went fairly quickly through them. If you have any questions on the CDC Legionellosis case report form or NED's investigations, let me know. Okay. Well, then, moving on. So, I was reading in preparation for this presentation, I was reading a review article, and it described Legionella investigations better than I could have ever described them. They are very individualized, and they can be difficult when you're trying to investigate for exposure because every facility is so incredibly different. So if you get a report of Legionella in a healthcare facility, I tried to compile a list of questions that you might want to ask of that facility. So these are, it's not an exhaustive list, just some things that either I've been asked to obtain or have heard others asked to obtain from the facility. And I would encourage you, if you get a case in a long-term care facility or a hospital, to go back to this list and see if you can't answer any of the questions so that you might be able to identify the exposure. There are a couple of things that are probably case-specific, but there are other questions that are pretty general and are going to apply to every investigation. Find out from your facility if they know their baseline incidence of respiratory illness or pneumonia. We can't decide if there's an increase in incidence or, a possible outbreak if we don't know what our baseline burden of disease is. The best person in the hospital is probably going to be your infection control nurse. And a long-term care facility, if they have an infection control person, that would be great. The director of nursing would also be a good contact in those facilities. Sometimes in long-term care facilities, it's nice to get a copy of the patient's full medical record. A lot of times for the staff to think back and recall if the patient has been in and out of the facility, if they've gone, if they stayed at home with family, what the possible exposures were for that patient is kind of hard when they're dealing with so many. So if you can get a copy of the medical record, that will help you in determining exposure. Obviously, any recent construction, any issues with plumbing, are there any sources of water that may cause aerosols? Some interesting things that I think are important to ask are in-room misters. Like my daughter has a cold steam vaporizer that we use, and I'm pretty bad about putting tap water in it. So do these residents of long-term care facilities have those vaporizers in their room? Do they have a fountain that might mist or cause water that they're filling up with the water in their bathroom? And then also respiratory equipment, any kind of whirlpool tub or anything of that nature. And then if you do have respiratory equipment involved, how do they clean that equipment? Are they using tap water? Are they using sterilized water? When they fill the equipment, are they using sterilized water? And then the same goes for tube feeding equipment, because there are rare cases associated with aspiration. Are they using tap water to clean the tubing, or are they using sterilized water? I put a link on here to the CDC's Legionella Environmental Assessment Form. This is a really good form for environmentalists if you send them out to inspect the facility. It goes through all of the potential exposures in hotels, in long-term care facilities, in hospitals, organizes it in a very easy to read fashion, and it will give your environmentalist an idea of what you're looking for when they go into the facility. And also, in order to test for Legionella, if the facility would like to, the CDC has an elite lab program in there specifically for testing for Legionella. This website will take you to which labs in Kentucky are certified to test for Legionella, should the facility want to do that. So, I'm pretty early. If anybody has any questions, I'm available for questions. And then Stacey Davidson is here too. I'm going to throw her under the bus. If you have any questions for her, she's going to help me out.
Any questions from the field for Katie or Stacy?
Katie, this is Dorothy from the Purchase District.
Uh-huh.
And I'm kind of curious on this distilled water versus sterile water. Distilled water, after it's opened, isn't sterile. And so is there a differentiation there? Is there a higher risk when you're using the distilled instead of sterile water?
That's a good question, Stacey. Do you know? I will have to investigate that because I see what you're saying. I mean, it shouldn't be contaminated, but if you have aerosols in the air, I'm not sure. Let me investigate and get back to you.
Okay. Thank you. And then I was kind of wondering about this confirmed case versus suspect case. We often sort of fluctuate knowing what to check on a box like that.
Sure.
And so of that list of 6 items, at first I thought everything under confirmed was the confirmatory test and everything under suspect was the suspect, but I see now it's 1, 2, 3, 4, 5, 6. And so any one of those 6 could either confirm or suspect. And did I miss the main point there? What is the actual confirmatory? Only the culture of the urine, or?
Culture is confirmatory. The urinary antigen test is confirmatory. And then a 4-fold rise in antibody titer would be confirmatory. But it's just, we don't get very many of the second test to confirm the 4-fold rise. So the most often you'll get a urinary antigen and then, if you're lucky, a culture.
Okay.
Does that make sense?
Yeah. I wonder why they run the first test if they're not going to check it again on the antibody. It seems funny.
Yeah. We agree. We don't know.
Okay. All right. Well, thank you.
You're welcome. Any other questions? All right. So contact information on the back. If you think of something you want to get in touch with us, I'm on here, and Stacey Davidson, who's the nurse consultant for Legionella, is also on here. So just shoot us an email or give us a call.
Thanks, Katie. Appreciate it. Next, I'll go ahead and ask Shelley Wood to come on up. Shelley is a registered nurse within the Division of Epidemiology and Health Planning. We talked the other day, Shelley gets all the emerging infections and diseases. It seems like she was our Ebola subject matter expert and still is. And then when Zika surfaced, she took on Zika as well. So thank you for providing timely update, information, and guidance to us today about Zika. I have your presentation loaded unless you have a different one. Okay.
Can we do it?
Yep. Okay. We've got an updated Zika presentation. As you all know, the information, the guidance that's coming from the CDC changes on almost a daily basis. So we want to make sure that you all have the most current and accurate information available to you. We'll get that loaded right up for you.
Thank you, Joey.
Sure. I think everybody knows you, Shelley, but you might want to introduce yourself just in case and tell a little bit more about yourself. Okay.
Excuse me. Joey's right. This information is changing on a daily basis almost. And so my PowerPoint that had been approved on the 5th was already out of date by the 12th, and then again by today. So anyways, I tried to run through this morning. I know that we will have some that we need to update, but still I wanted to go ahead and present the most up-to-date, even though the printout that you have, I realize there'll just be a few changes. Okay? So these are your objectives, and I'm not going to bore you because I'm cramming a whole lot in 30 minutes, so it's kind of nice that Katie gave me a little bit of extra time.
You've got a little bit of extra
I have a
time.
little bit of extra time, so I won't bore you with the details. You're going to know Zika as well as I do by the end of this presentation. Let's just say that. I'm going to give you some background. It was discovered in 1947 in the Zika forest in Uganda, and it was discovered in a caged monkey. And this happened during research when they were researching yellow fever. And those of you that know of yellow fever, that's also a flavivirus that's been around for a really long time, and we don't hear much from it anymore because of the vaccination. So in 1947, it was discovered in the caged monkey, and then in 1948, it was isolated from an Aedes mosquito, the Africanus, which was in the Zika forest. And that's how they found out that that was the reservoir of the Zika virus. Still, it didn't transmit or wasn't isolated into the humans until 1968. And then there was an outbreak in 1971-75. That was in Nicaragua. And that's when they discovered that it had human transmission, or not transmission, but it was able to be transmitted to humans. And then they had 1951 to 1981 serological evidence of human Zika was reported from other African countries, so it was going throughout the continent, and it spread to Asia. And so right there, they knew that it was isolated from the Aedes aegypti mosquitoes across the board in Africa and Asia. It stayed in Africa and Asia all the way until 2007, and in 2007 it came outside of that, went to the Micronesia Islands, to the Yap Island, and that was the first time that it had been detected outside of Africa and Asia. In 2010 it went to Cambodia. All this time it's been a self-limiting illness. No problems, maybe a little fever, maybe a day of rash, maybe some joint pain, but really it was self-limiting, just like chikungunya is self-limiting. Yellow fever's been self-limiting, so it was some of those type of self-limiting viruses, and Zika was among those. And let me just say, ZIGV is the abbreviated version of Zika virus. And so sometimes people are like, I think you have a misspelling on your presentation, but no, that's the way the lab, and that's the way that you'll see it written sometimes. So Zika virus. And so anyways, after Cambodia, it was still self-limiting. There was no change. In 2013, 2014, it went to the French Polynesia Islands. And the French Polynesia, I'm horrible at geography, so I'll just up-to-date you. It's like 67 islands in the Pacific Islands. And so it hit that French Polynesian Islands. It went outside of that into some South Pacific Islands. Cook Island and Easter Island you may have heard of. And still, it wasn't studied. So even though they expect, or some people have said that they suspect that it was brought over to the Rio de Janeiro Games. However, there were no French Polynesia people that were participating in those games. And so they've gone back to do some research, and now they say, well, there was a kayak event there, a huge kayak race in Rio de Janeiro. And so in that, all 4 countries that had an outbreak in the French Polynesia, like Cook Island and Easter Island, they did participate in those kayak games in Brazil or in Rio de Janeiro. So they're looking at that. Now let me say they are going back retrospectively and looking at the outbreak that occurred in French Polynesia, because no studies were done because it was self-limiting and they didn't think they needed it. So in 2015, April of 2015, that is when it first hit Brazil. So remember, think about your pregnant ladies, because we know now that that's what made Zika hit the news, is because the detrimental effect on the fetus. And so think about your pregnant ladies who were pregnant in April and maybe at the end of their first trimester. In October, that's when they started seeing a rise in microcephalic babies. And so they were putting 2 and 2 together. I will say this, that CDC has not released anything that there is a direct link between Zika and microcephalic babies, although they have released that with each test and the more evidence that comes in, there is a stronger link, but they have not directly linked it. It is not a causal link at this point. That may change tomorrow, but as of today, that's where we are. In 2016, the Pan American Health Organization reports that it had spread out through 28 countries. That has now been updated to 30 countries. Okay, so we have 30 countries throughout the Pan American, South America, Central America, Latin America. Many of those fall into the category that they are now known to have active Zika transmission. Let's talk about it in the United States just a minute. It became nationally notifiable this year, last month. We only know of imported transmissions until 2nd of February, when it became known as a link to sexual transmission. I will say this, it has been found in the semen 3 times. 3 times. But remember, whole lots of studies haven't been performed, but some have been performed. So in 2008, it was found in semen and was suspected to have caused transmission. In other words, the man went to a Zika-affected area, got bit, became infected, came home, and spread it to his wife. So transmitted it to his wife. And then in one other case, there was a case where it was detected, but the viral load was not determined. So just because it's detected in the semen doesn't mean that it's capable of spreading the virus in the semen. So that one, no transmission was detected, but although the Zika virus had been detected in the semen. And then the one recently in Texas, he had traveled to Venezuela. His wife stayed home. She came home. They had sex when he did come home, and sexual transmission because she's now Zika positive. As of today, 52 cases in the continental United States. 52 cases in 17 states. We have 1 case of sexual transmission that occurred in Texas. Okay? There are an additional 10 cases in the U.S. territories of Puerto Rico and Virgin Islands. Most of the cases are in Florida and Texas. As of now, there's no local transmission. By vector-borne, I should say. No local transmission by vector-borne, which is the primary route of transmission. I'm going to take you back to the geographic distribution of Zika, 1947 to 2007. In the little red circle, I don't know if you can see it on your printout, but the little red circle to the right, that's Yap Island. So you can see how far outside of Africa and Asia it had traveled. And they suspect that, of course, arrived on the island by a traveler. So it was an imported case. It was an isolated incident. People got infected. It went away. Okay, so it was just that one outbreak. Here are several countries where there are current active Zika transmission. And the WHO declared global health threat of international concern the 1st of this month. So there's up to 30 countries. So if you're traveling, be sure to wear your mosquito repellent. I'll put my PR. And then here's the Zika transmission cycles. This is where we start getting exciting about Zika. I stole this from a COCA call. I love this slide. To the left is the jungle cycle where the mosquito bites the primate and the primate, the mosquito bites the primate and infects him, and then the next mosquito bites him and gets it. So, we have this ongoing cycle where that's going between the mosquito and the primate and the mosquito. But when that mosquito that bites the primate can also bite a human, that's where the human transmission comes in. There's not typically that human-to-human transmission cycle. And so that's why you don't see that on here. However, there is now evidence about sexual transmission. Okay? So now it's the human to mosquito to human to mosquito. So it's still a mosquito-borne virus. It's still a vector-borne. Not all mosquitoes carry it. Only certain species, only the 80 species actually has been known to carry it. And here's the primary route of infection is via a bite of an infected mosquito. The one on the left is the albopictus. You may have heard this referred to in Kentucky, of course, as the tiger mosquito. Sometimes you can see that. They have white on them, not down necessarily down their back, but on their thorax. This albopictus we have in Kentucky rampant. We have tons of them, thousands of albopictus mosquitoes. The Aegypti, we have about 1 in 5,000. So, in other words, when they do these entrapments and count our mosquitoes, about 1 in 5,000 mosquitoes is the Aegypti. The Aegypti is the known competent vector. This is the one that's highly known to spread the Zika virus. Fortunately, we don't have that. We have them, but not in large amounts, okay? So about 1 in 5,000 we do have. The Aedes albopictus, this would be really dangerous if it gets in, if they are known to be able to transmit the Zika virus, only because they don't overwinter, so they can spread the virus in their egg stage. So in other words, mosquito lays eggs one summer and goes through the winter and it frosts and, you know, it kills all the mosquitoes, supposedly. And so in the next spring, the eggs just continue their life cycle. So they still have the virus. So that's how they get that. It's spread through usually through the females, the biters. Both of these species are extremely aggressive daytime biters. And that's why your normal mosquito prevention education does not work. Because, you know, typically in that you say, stay indoors at dawn and dusk. You know, those don't work. These are aggressive daytime biters. They do not fly. The Aegypti, if it's born in your backyard, it dies in your backyard. You know, unless the wind carries it, it's not going to go anywhere. These mosquitoes are called container mosquitoes, and they breed in your home. So they're aggressive. I read one thing that kind of appalled me, but I didn't see it anywhere else, so I didn't put it, but it said 50 times. They bite 50 times in 15 minutes. They're aggressive daytime biters. So they really are. So that's why the normal education doesn't work. So that's why we need to start really getting the messaging out to where you're mosquito repellent. That's probably the number one thing that we can do to prevent it. Zika transmission, we said the primary route is through mosquitoes, but there are other modes of transmission. I also stole this slide from the Coca call. Maternal fetal, interuterine, and perinatal. We know this because of the detrimental effects that we suspect is associated with the Zika virus. And then sexual transmission, which we've already said, blood transfusion, and for this reason, the Red Cross has put out a warning that they will no longer accept any donations from any traveler that's traveled to the area within the last 28 days. So that's going to be their cutoff. They've already put that out there, 28 days for you to be able to donate any blood product of any kind. Lab exposure, and then as we were talking about before, it was detected in the semen earlier before it was noted to be a mode of transmission. It has been detected in breast milk, and it has been detected in tissue. So saying that, theoretically, it could be spread through that. There are no cases anywhere right now with that. Mosquitoes that carry the Zika, I got to get down on these mosquitoes and make sure you guys understand the difference. So we have the blue, which is the Aedes aegypti, and you can see that it's just south of Kentucky. But remember, I did say that there are a few stragglers that come up to Kentucky. they're not very far north. The Aedes aegypti aren't, but they are both aggressive daytime biters. And Aedes aegypti has spread it throughout history. It was in Africa, and it had spread it in Africa. When it was in Yap Island, it was spread by the Aedes henselae. When it was in French Polynesia, it was spread by Aedes polynesiae. So, saying that, the Aedes albopictus is probably a competent vector because it has been known to be infected with Zika. However, it has not been proven that it can transmit it yet. And so, let me preface that by saying, when this hit Yap Island, Aedes henselae was never a known vector at that time, so it had crossed species. When it had hit into French Polynesia, the Aedes polynesiae was not a known vector. So they're both of the Aedes family, different species. That's what we have in Kentucky. We have an Aedes family, and we have albopictus as our primary Aedes vector. So there's no reason to think that it will not cross into our population. That's information from Dr. Grayson Brown, and he's a world-renowned entomologist who happens to be at the UK. So it's nice to have him here. So there's no reason, but at this point there's no documentation of it. It's found throughout Kentucky. We'll go into the pathogenesis. The entry into the humans through a bite of an infected mosquito, this is by far and large the most primary way. Incubation period, notice it has an asterisk because as of right now, CDC has not put out an incubation period. It is unknown. There's not enough science, hasn't been enough studies. I've read anything from 2 to 3, 2 to 5, 2 to 7, 2 to 12, and I've even read some flaviviruses go longer. So they have not put that information out, but I felt like I needed to at least put a number out. It does seem like they're looking at about 12 or 13 days, about 2 weeks, because of some of the guidelines they're putting out. Looks like they're leaning towards that way. This replicates initially in the dendritic cells near the site of inoculation. You know the dendritic cells are part of the cytoplasm, and this is probably why it's always been associated with a self-limiting virus. It's a flavovirus. However, there's 2 types of flavoviruses that have been found to infect the cell nuclei. That's the Spondiwini and the Zika. So it's the only 2, and that's probably the difference between, it infecting the nuclei and infecting just the cytoplasm is probably why it's crossed into the congenital and causing those abnormalities during formation of the cells. So that kind of makes sense when you look at that. There's only the 2. The other flavoviruses that are, that this is more geared to in the dendritic cells near the site of inoculation and spread to the lymph nodes and the bloodstream, those are your yellow virus, West Nile, Japanese encephalitis, chikungunya. Those are all flavoviruses. And those have not been known to cause any congenital abnormalities. So that's where we are on that. About 2575, I think it's changing to 2080 now that they're doing further studies, but it was 25% of people infected develop symptoms and 75% remain asymptomatic. It looks like they're going with 2080 now that the new studies come in. This 2575 was based on the 2007 outbreak in Yap Island. So here's a demonstration of the incubation period being, different. 2 to 7 days says the WHO, 3 to 12 days says CDC, but even though it's not written in some of their studies, they're showing that, and perhaps maybe longer when you talk to people that have studied flavoviruses extensively. So the characteristic clinical findings are acute onset of fever with a maculopapular rash. However, this can also be pruritic. We did hear that on the call. Several of the people have been pruritic. So don't get locked in on the maculopapular rash. Get locked in on the rash. And then arthralgia or conjunctivitis. Clinical illness is usually mild with symptoms lasting for several days to a week. realistically, a lot of the people say they've been sick for like a day and a half. You know, I was sick for 36 hours or, you know, not long. Severe disease is uncommon and hospitalization is rare. There's 2 neurological conditions. It says associated with. I probably shouldn't have said that just yet. It has not been linked. We've discussed that with Zika infection in Brazil. Brazilian has said that they link it. CDC has not. So microcephaly and Guillain-Barré syndrome. This is our occurrence of symptoms, and this is where they got their, you know, they must have 2 of the 4 clinical symptoms to be in order. Well, they don't even have a case definition yet, but in order for you to order testing, they have to have 2 of the 4 of these. Okay, and you can see over half of the people had conjunctivitis, joint pain, fever, and maculopapular rash. But we have learned with the Brazilian outbreak that it's also a pruritic rash. And then I just gave you a little table comparing dengue to chikungunya. There's really no way to tell the difference. Now, we've seen several cases of chikungunya, and all of our chikungunya has been spread, has been imported. We do not have any local cases yet. However, the albopictus is known vector for chikungunya and for dengue, so one of our primary mosquitoes, especially the Aedes species, can carry dengue and chick-V. So the chikungunya, the difference that I usually hear is this. When they are positive for chikungunya, they usually have, what I've noticed, is a small joint pain. You know, they complain of hands, wrists, feet, ankles. It's the small joints. When they were sending out information, when CDC was sending out information for Zika, they said, let's don't narrow it down that far yet. And honestly, they're not seeing it in that yet. We don't even have a case definition for chikungunya yet. And so we've been dealing with this for 2 years. Right now, in order to get tested for chikungunya, you must have 2 joints, okay? So it just says 2 joints. Complain of pain in 2 joints, and then a fever. So that's your 2 clinical criteria that must be met in order to have chikungunya testing. We've opened that up a little bit because if you're testing them for Zika, we're also testing them for chikungunya and dengue. This takes about 3 weeks to get these tests back. But you can look on there. Actually, chikungunya seems to be worse on the adults, really, because chikungunya is taken from the old African word that literally means to be stooped over. And that's what you hear. When you hear of these people that have chikungunya or, you know, want to be tested for chikungunya, we're almost able to spot them now from the symptoms. You know, like I pretty much know which ones are going to come back positive and which ones are going to come back negative. And they all complain. Like, I had an 18-year-old that had to be helped off the toilet by his dad. You know, like, that's not a normal situation. When I say stooped over, and they all say, you know, they had difficulty walking or they had difficulty, you know, ambulating in an upright position. So they really are stooped over. So it's really funny because they're like, I'm like, did you have difficulty walking? And they say, yes, I couldn't hardly stand up. So that's so funny because that's the African word, to be stooped over, you know, so you can kind of see where they got that from. And then, talked about that. Oh, did I go backwards? And so Zika surveillance, you know, we're at the beginning of this. We're, the local health department's job, I guess, is coordinate with local providers to consider in travelers with acute onset of fever, a rash, arthralgia, or conjunctivitis within 2 weeks of return. They actually say 12 days. Inform and evaluate women who plan to travel or have traveled to areas with Zika virus transmission while they were pregnant or immediately right before. Coordinate with local providers to evaluate the fetuses and infants of women infected during pregnancy for possible congenital infection and microcephaly. Be aware of possible local transmission in areas where Aedes species mosquitoes are active. Here's your case definition. They're working on it. Okay? But in order to be tested, and we'll go into that, You have to have 2 of the 4 clinical symptoms, okay? Fever, rash, joint pain, or conjunctivitis, 2 of the 4. Now, asymptomatic pregnant women, if you're pregnant, you're going to be tested. So if you have traveled to one of the areas that's known to have active Zika transmission, you will be tested. They want to test you at 2 weeks, between 2 and 12 weeks, and it may be serial, say this 3 times, serial serologic testing. Serial serologic testing. They have gone to this. I know they released the guidelines on January the 19th, that CDC had released that in an MMWR. It was actually an early release, coming out with some guidelines and saying, okay, if you're symptomatic and you're pregnant, we're going to test you and we're going to do serial ultrasounds on the infant to measure the growth of the head to make sure that we are up to par. Well, by February the 5th, they did another early release and said, scratch that. Now what we're going to do is we're going to test any woman who is pregnant that has been to the area. Okay, so now what they've done, they said they've listened to the local health departments and the state health department and the providers and said it was very cumbersome to do serial ultrasounds. Therefore, they did serial serological studies. And so what they're doing is watching the IgM to see if there's double fold. Flaviviruses can have a false positive. There's a high rate of false positive. That's why they are really being a little more strict on who they're testing, and that's why it's coming through the state health departments, because CDC doesn't want to be bombarded with all these providers and health departments and state health departments sending all these specimens in when they may not even meet the clinical definition, and it may end up causing some errors, delays in getting people that need priority in testing, and that's the pregnant women. So here, this is pretty current. History of travel to Zika-affected area and symptomatic within 2 weeks of travel. This is outdated. Pregnant women with travel to Zika-affected area and any traveler who develops symptoms within 2 weeks of return. This is the 19th guideline. I didn't take it out because it had been approved, but I did throw this one in on it today. And I don't know how well you can see from out there, but I'm going to walk through this just a little bit. A pregnant woman with a history of travel to an area with ongoing Zika virus transmission, you test them, whether they're symptomatic or whether they are not. This information is really, it seems like the OBGYNs are really, have found out about this information. I'm getting a lot of calls, and I'm sure you are too. Positive or inconclusive for Zika virus, that's when they're going to say, okay, you're positive, so now we do need to do the serial ultrasound so we can watch the growth of the baby. If they're really far along, then they're going to consider amniocentesis. And again, there's a high rate of false positives. If the mom is tested, she's pregnant, she comes back, she's tested, and she's negative for the Zika virus. I'm going to the right side of the algorithm, and this algorithm can be found on the CDC website. It's the MMWR that was released on February the 12th, and it was early released on February the 5th. If they're negative for Zika virus, which has been the majority of ours so far, the fetal ultrasound to detect a microcephalic or intracranial calcifications, they will do that one time between week 18 and week 20 gestational period. Okay, so if they're negative at 12 weeks after, so we may have to do serial. Somebody coming back 2 weeks ago, she's not pregnant, she went to the doctor, she'll get tested at maybe 2 weeks, 6 weeks, and 12 weeks. After the 12 week, that's when she'll have her normal ultrasound. After that normal ultrasound, if it is normal indeed, they will, that'll be the end of it. That she'll fall under the routine medical care or routine prenatal care there. If microcephaly is detected, they'll retest the woman because, see, we're under the negative side, so they'll go back and retest her.
Would you mind to send me that revised?
Yes, absolutely.
And I'll send that out to everyone.
Absolutely.
Okay, thank you.
Laboratory test for Zika, no commercially available test is available. This is all new. Remember, it hit Brazil in 2015, so they are scrambling to get the test, to get everything up and running. And that's one of the reasons why they haven't released it commercially yet, because it just hasn't met all of the verifications that it needs to go through the process. So current testing is at CDC. They can currently test real-time PCR, and we usually collect that while they're sick. And then after that, they test the IgM. As of right now, there are no known testing for IgG. We've tested 2 people that I feel like, we should have done an IgG on, but it is not available. I had already mentioned there's a high rate of false positives due to cross-reactivity with other flaviviruses. In other words, if you had your yellow fever vaccination, when traveling to an area, there's a great chance that you're going to be positive for Zika. And then collection of the Zika specimen. This is what I get most of my calls about, actually. What do I collect it in, and what do I do with it, and how do I go through this? You collect 2 tubes of blood via venipuncture. It can be 2 red tubes or 2 serum separator tubes. The serum separator tubes are your tiger tubes. They're the ones that with the old rubber top was tiger topped. They were either yellow, red, green, gray, 2 different colors. That's a tiger top serum separator tube. Nowadays, they have the plastic lid on them, and so it's like the yellow with the red stopper in the middle. That's a serum separator tube. You can identify a serum separator tube because it has the gel in the bottom. Excuse me. And the difference is that if I take a red top tube and I spin it down and I leave it for a day, it's going to go back together. There's nothing to keep the serum separated. Hence the name serum separator tube. If you take a serum separator tube and you spin it down, it's going to stay separated. After that, the labs do not need to draw the serum off. They spin it down in the tube, and you can put it in the refrigerator or you can send it immediately to us, and this is the address. So it'll go here. Let me say, don't worry about this. When you call for an approval number, you'll be given these instructions, okay? Treatment for Zika, there's no specific antiviral treatment. It's supportive, but one thing that you do want to do, since we do not get the test back, and it is dengue cannot be ruled out, you want to avoid the NSAIDs. So no aspirin, no aspirin, no Motrin, no Aleve, all of that good stuff. Investigation, we have this on a sheet too. You can either obtain it and give it to me, or I'll send you the sheet. It's got demographics, age, date of birth, sex, where did they go, travel history, everything that you can imagine. What are their symptoms? What was the onset? How long did it last? If they're pregnant. The investigation continued. We are still doing the approval from KDPH right now because CDC has not opened it up. Our state lab is actually on the list in queue to receive testing. So we hope to be able to do that as soon as they release it. They haven't released it yet. After hours, I say this with the caveat of there's nothing about Zika that is emergent. There is nothing about Zika that is emergent. It can wait. It can wait a week. It can wait a day. It can wait. Draw the blood, stick it in the refrigerator, spin it down, stick it in the refrigerator, and call the next business day. It's fine. If you have a provider that just has to talk to someone at the state, as they did Miss Kelly, I think it was on Monday at 3 o'clock in the morning, they can call the after hours number. And that's our regular 8889 report number. Send specimens to DLS and provide education, and you'll also be reminded to do that when you talk to your providers. And that's to prevent transmission into the local mosquito. And that sounds kind of funny because, I don't know, when you say, don't only wear your mosquito repellent while you travel, but wear it 2 weeks after you return because we don't want our mosquitoes to become infected. We're public health. We didn't think of us as protecting the mosquitoes. But when you protect our mosquitoes from becoming infected, you in turn protect the public. Also, that needs to be added to this is preventive measures for sexual transmission. The newest recommendation, they did release this, I think it was on the 5th of February, MMWR for males returning from Zika-affected areas. It is, if they come home and they are having sexual intercourse with someone that's pregnant, that is recommended that they wear a latex condom throughout the duration of the pregnancy. Wow, what a bummer. But now that's it. I mean, they're pregnant, and now all of a sudden they still have to wear the condoms. You got to wear the condoms, guys. And then they have not put a date. They have not put a time frame on it. What CDC last released when I talked to them on 12 February, asking about this, was we're given the information. It's up to them to make the decision whether to do it or not. In other words, where Red Cross is saying no donation for 28 days, they're hesitant to say wear your latex condom for 28 days. Now, we know with pregnant women it's going to be throughout the duration, but what about, someone that's not pregnant? They haven't put a time frame on it. What they say is, I'm giving the information of what we know. It's up to you to make the decision. I've talked to a lot of providers about this. Most providers in the state, seems like through the state, are saying 60 days. They're telling them 2 months. So they're going, actually what they're doing is doubling what the Red Cross has done. So that's what they're doing.
Would you mind to share with the group the conversation that you had with the gentleman that he and his wife wanted to start a family?
We did. Yes. We've had that a couple of times already. That's come up. I've been called from health departments, providers, gentlemen, ladies. They're wanting to become pregnant, and so, like I said, the CDC is not releasing the time frame. It's not supposed to affect future pregnancies. Okay, so if you come back and say the gentleman does have a Zika, and remember 80% of them are suspected to be asymptomatic, so he would have no way to know. If he's traveled to a Zika affected area, then it is encouraged that he does not, that they don't start a family or try for conception for at least some period. And so it looks like most doctors are saying 60 days. I've talked to some fertility specialists, and he was saying 3 months. He said, we're not going to start fertility treatment until, 3 months.
Thank you.
But I haven't seen that in writing, and CDC has not released that yet. So I'm a little hesitant to say it. But like we say, it's changing. This is emerging infectious pathogen, so it's changing. I could probably give a different presentation in 2 weeks from now. I probably will have to. So to report a case, it's within 1 business day, the same as dengue or chikungunya. Probably we will all know it together. The CDC is actually releasing the results to the public or to the local health departments. And I usually get notified because Matt Johnson at the lab will pick up the phone and say, hey, this is what we have. So we kind of are all on board. Right now, we've only had negative. So call after hours. Remember, it's really not necessary. If they're just dying to ask a question, Miss Sandy will be happy to answer them at 3 o'clock in the morning. And then you can call me directly the next business day. Send an EPI 200 form. And the KDPH, I will report to CDC via our ARBONet. Implications for public health: best way to prevent Zika is to avoid mosquito bites, and that means barrier. And remember, you can't do the typical old-time used to be mosquito precautions. You can't avoid dawn and dusk. This is in your home. This is in your backyard. This is aggressive daytime biters. So you need to tweak your mosquito precaution teachings to just that. These are container bred. Until more is known, pregnant women should consider postponing travel. That is a message that Kentucky has opted to encourage. CDC put that out as well, and so we've adopted the same. It is, until more is known, pregnant women should consider postponing the travel to any area with active Zika transmission. Healthcare providers should contact their state or local health departments about testing patients with compatible travel history and symptoms for Zika. And then, now I think we have to add the sexual transmission. The doctors have been really good. They've been really receptive to this. When I say, it's encouraged, say the spouse went to Puerto Rico or wherever with his wife, and he comes back, she's okay, she tests negative. We still recommend that he wear the condom. CDC still recommends that they wear the condom throughout the duration of the pregnancy because he didn't get tested. because he's not symptomatic. And so they haven't opened up. I had a case like this, and they said, no, we're not going to test him, so they didn't test him. Now, the focus is on getting symptomatic people tested and getting their pregnant women tested. Prevention and control, I think we're about to wrap up. Reduce contact, that's the barriers. We've talked about it a million times so far. Remove and modify mosquito breeding sites. One of the things that I found very fascinating is they can lay like 300 eggs in a bottle cap. So when we say water, we say remove all standing water. Something else that's very interesting is that with the Albopictus, which is the one that we have the most of, if they lay eggs in a tire in the middle of summer and it's a drought and they go through the winter and the next spring, it comes in a lot of rain. Well, guess what happens? The eggs take right off where they left off. So they can survive the winter, they can survive the drought, and as soon as water is added, presto, they just take right off. So pretty wild to learn that and to think about that. That blows my mind because I didn't know that. I know more about mosquitoes than I ever did.
Yeah.
My next career will be an entomologist. Okay, so our goal, we talked about this, is to protect the infected people from mosquito exposure. That's why you really want to put out that messaging. Wear mosquito protection while you're gone, but also for 2 weeks after you return. If we can keep it out of our local mosquitoes, that's great. And then also note that period of viremia may be longer, because CDC actually says for the first week to wear the mosquito repellent for 1 week. We've gone out to say 2 weeks because that's the incubation period. There is no vaccination yet, may not be a vaccination. They're working on it, just like they say it's not worth the money to invest in IgG. Okay? Now, I wanted to just throw this in here this morning. This is Kentucky testing as of 8 o'clock this morning when I made this slide. Total tests approved, we've approved 24, so we've had 24 travelers, 20 females, 60 of them were asymptomatic and pregnant, by far that's our most. 4 females were symptomatic. 2 of those symptomatic were pregnant, and 2 of those symptomatic were not pregnant. We have 4 males, of course all of those were symptomatics. We have 4 tests as of this morning that have been resulted back from CDC, and they are negative. Okay, we had 1 positive for chikungunya virus. He does have a history of yellow fever, flavivirus, like 7 years ago, but he was symptomatic. He didn't exactly fit the clinical picture I was describing of chikungunya earlier, and this gentleman, he was one that we monitored for Ebola, so he's a world traveler. Let me tell you, he's getting tested for everything when he returns. He's either getting monitored or tested, and so he's back. He's the one that tested positive for chikungunya. So we don't know if it was actually an exposure with this travel history. That's all I have. If you have any questions, I'll be happy to take questions. Joey said she's going to send this updated PowerPoint out to you guys. If you have anything that I didn't cover, feel free to ask me. And that's it. Have a great day. Yes, ma'am. I have a question in the room.
And I came in late, so you may have touched upon it, but the symptoms for children, are they any different from adults?
Not as of right now. Not as of right now. We have not tested any children, and there's been nothing released on children. CDC has not put out any recommendations that I have seen that have come across to our desk or updated on the website about children.
Are they including Florida and Texas as a travel area?
They are not. There's no local transmission. All of Florida's, even though they are known to have local transmission of chikungunya, they have not been demonstrated at this time, even though they have the Egypti, which is a very competent vector. It's not been discovered yet in their mosquito population. And they really do a great job of surveillance, not of their humans, but of their mosquitoes. So they pretty much know what's there. Dr. Grayson Brown said this yesterday. We will be able to tell by this summer if the Aedes albopictus is going to be a vector, because if it moves north of Florida, he said Orlando specifically, but if it moves north of Florida, you can suspect that it can be crossed through albopictus, because he said if it wasn't able to be, they wouldn't be able to carry, they wouldn't be able to cross that kind of border there. So that's his cutoff. Most of the, so therefore, to answer your question, no, we're only looking at international travel. We have gotten calls from a lot of travelers with that concern. Now, what I do is, and you may, at the local health department, if it comes out and they're asking you about this travel, ask if they have symptoms. And if they do have symptoms and it does sound like chikungunya, then let's test them for chikungunya. Because remember, to test for chikungunya, you have to have joint pain in 2 or more joints and a fever. So if they meet that criteria, we can go ahead and test them for the chikungunya. Any other questions?
I've got a question. I've seen some information on the news about the larvicide. Now, would you mind just to talk about that and how that has been currently ruled out as a potential way that Zika virus is transmitted? Is that, you want to touch on that just a little bit? And I don't want to throw you under the bus, but I mean, just...
There are actually a lot of, let me say, conspiracies, theories, I don't know what you say, but what you would like to call it. But let me say this. We've seen where they genetically modified mosquitoes. And so saying that with the genetically modified mosquitoes, some people say that's what's causing the Zika virus, because they went out and they genetically modified these mosquitoes. And now these genetically modified mosquitoes are biting us, and that's why we have this. Well, there's no truth at this time. It has not been linked. When they do that, when they genetically modify them, what they do is they release thousands of male mosquitoes into the population that have been genetically modified not to carry the virus, not Zika virus. We're talking chikungunya, dengue. We're talking dengue specifically. Those are the ones that they've done because dengue is endemic in certain areas in the states. And so that's what they've done. They brought this to Florida, to my understanding, last summer and said, do you want us to, release these male mosquitoes? Because essentially what you would do after 2 or 3 rounds of that, you would decrease the mosquito population because they're sterile and so they're not breeding and there's all these males. So a life cycle is about 30 days of a mosquito. So they say a couple of rounds of that, especially with the Aegypti, because the Aegypti, when I'm talking about the eggs being able, and the larva spreading the virus and surviving the drought, the Aegypti aren't like that. The Aegypti gets killed with the first frost, it's done. And so that's the ones that they have done that. Also with the larvicide, they've been a lot of spraying, and they've been even crop dusting from the air, larvicide in the containers. That's what they have. You've probably heard some conspiracies that the larvicide is actually what they're killing the mosquitoes with. That's what's causing the congenital defects. Yeah. So there's a lot of conspiracies. I can't think of another one that I've heard recently. Oh, vaccines. Vaccines are always thrown under the bus. So vaccines have been tied to it. So that's the 3 that I've heard the most of. And then the larvicide that they make now and the egg side that they do is really a lot safer than it's ever been, and they do even have some natural-based products as well. They say even if you can spray in your backyard, now the number one thing is not the mosquito control with larvicide, but more like empty your water containers, get your trash up, things like that. Hawaii actually was fighting a dengue epidemic when their first case of Zika, imported Zika, came, and so they were already for the past year with their public health campaign is Fight the Bite, which I love. And so fight the bite of the mosquito, and they had already been practicing, emptying water, standing water. Essentially, it's standing water. But they want you to wear permethrin-treated clothing, It's safe to wear DEET. Pregnant women can wear DEET. Wear your mosquito repellent. So be very vigilant about that. And then also sexually transmitted diseases, or sexually transmission of this virus. And you'll probably start hearing that question being asked upon entry to the emergency department, as weird as that may sound. Have you had travel or have you had intercourse with? I can't imagine that being the first thing that I ask you when you walk in the ER. But it is coming. Have you had intercourse with somebody that recently traveled to 30 countries? South America. Okay, that's it. Does anybody have any questions?
Would you mind to mention the call tomorrow for healthcare providers?
Yes, there will be a statewide healthcare call tomorrow at 1100 hours, and the statewide call is for any healthcare providers. We ramped this up with Ebola, and we have one every so often now to kind of bring everybody up to par. So Zika will be on there. We will give an update on Ebola. There's going to be an update on the Ebola assessment hospital and the infectious disease assessment, the extended infectious disease assessment. What else is there going to be on there, Katie?
Flu.
High-path AI and influenza. Yeah, so it's going to be a good call. You can put that out to your providers. We got a lot of information out via these calls last year when we were going through this with Ebola. It is a very good call. And you should have that information on that.
I send it out to the nurses.
Okay, and then Joey said she can send it out, and she has sent it out.
I've already sent it out to the nurses.
She's already sent it out. Okay, thank you.
Thank you, Shelley. Excellent presentation. Riveting presentation. I tell you, I was going to ask you when I wrapped up if you ever thought you'd know this much about mosquitoes from nursing school, and you beat me to it. You said the same thing. So anyway, as nurses, we learn and are able to be conversant on all kinds of subjects and topics in public health. So thank you for being a leader on this topic and subject matter expert. We appreciate that. Okay. Let's see here, Benita. Do you?
I just put it in. So.
Yeah, I got it here. Okay. Let me get you set up here. Okay, so next we have Benita Decker, who is the director for the Family Planning Program in the Division of Women's Health. She asked to provide an update, information about family planning services and our new fee-for-service reimbursement program. I provided this information, similar information, to the local health department directors at the CADA meeting in January. So I wanted to make sure that all of the nurse leaders and public health nurses out in the field receive the same information. And so she's pulled together this presentation for you all, and will provide you all an update. So thank you, Benita, for being here with us today, okay?
All right.
And I'll fix the screen here in just a minute. So.
All right. Thank you, Joy, for letting me come and talk to you all about just some family planning updates and what's going on in our world. But if you'll just bear with me, let me put my adolescent health hat on. I didn't know how well you all knew how well our teen birth rates are doing. This map is the 2014 teen birth rate. If I showed you the 2008 one, it would be really red and not so gray and blue. Just to show you this really quick, how we've fallen in our birth rates. In 2014, our teen birth rate was 34.5. Which is down from 38.7. If you look at 2008, it's down from 55.8. That's a 37.5% decrease since 2008. Of course, the nation's falling too, and we still stay 10 to 12 points above them. But at least we're kind of keeping with the trend, and we're working really hard to keep those rates falling. And really, you can see that, our poverty areas, our Appalachian areas, we're still, got some real challenges there, and we're working on that. So if you're working those health departments, That's what's, you're such key to this. That you are very much a part of what's going on. If we look at our Appalachian counties, you all are falling in your rates also, but not nearly as fast as the non-Appalachian counties. And of course, poverty contributes to that, and several other factors that we're addressing. But just really quick, before I get into family planning, I'd just like to talk to you about, we still have our Teen Pregnancy Prevention Strategic Plan. And, some say it's like 6 years old, but it's still so productive. It's really working, and we're continuing to implement that. We are still doing that personal responsibility education in middle and high school teens. And a lot of your health departments are participating not only through the Absence and Prep grant, but doing other activities out in the community and in your schools, not only to educate our kids about contraception or staying abstinent, but also teaching them how to make good decisions, how to own their decisions, how to fight peer pressure, how to say no and keep their friends and that kind of thing, and helping them, to see their future. And so that's a big part. You all, through family planning and access to health care, providing teens confidential and adolescent-friendly health care is vital to teen pregnancy prevention. Your counseling and contraceptive services are amazingly important. In fact, approximately 14% of our teenagers, according to the Youth Risk Behavior Survey, report that they don't have a trusted adult to talk to in their life. And sometimes that teen shows up in your clinic, and you're the only person that they can trust to talk to you about their problems, about their concerns, and you may be the only person that will take time with them and to talk to them about health issues or what's going on in their life, and to listen to their stories. So listen to your teens as they come into your clinic, and help them own their decisions, help them work through their decisions, and help them, because they don't have that at home often. And so realize the value in that. And not only are you preventing teen pregnancy, but you're also you're really improving your community and improving the chance of that teenager having a better life. One of the other things I will say about the teen birth rates and through our education is that in 2015, the Youth Risk Behavior Survey, 42% of our high schoolers said they were sexually active, and that is compared to, in 2011, 52%. So education is working to help our teens make better decisions. Also, educating our parents and our communities is still a vital thing that we need to be doing in our local health departments, and also you staying aware of what's going on in adolescent health initiatives so that you can provide the best care that you can. So I'll take off my adolescent health hat, and I will put on my family planning hat, and let's talk about reimbursement updates. Okay, we started the reimbursement plan in July of 2015, where we're reimbursing fee for service. So we're giving you back what you do for your family planning clients. When they come in, what you code on the PEF is what you get reimbursed for. As of July through January, which is about 58% of the year, local health departments overall have spent 18% of their allocations. Now, some of the health departments are really up there and spending 55% of their allocation, but many health departments are not spending their allocation. We know numbers are down, but we're also wondering if you're coding your PEF correctly. So make sure that you're really adding those services on for those family planning clients that you're actually doing so that you can get reimbursed for them. We also looked at the fact that in the beginning, we did not, because we didn't know how spending would go, it was a new program, we did not put some of those additional services that are kind of sort of adjunct to family planning services, such as STDs, et cetera. And so we also were reimbursing at 90% because of the match. And here's the changes that we decided to make. So retroactive to July 1st, we're going to reimburse at 100% instead of 90%. And that will be, we're working with CDP to make those changes. And so we will get that reimbursement to the local health departments as soon as we can get that changed through with CDP. So we've reimbursed you at 90, you'll get reimbursed more back at the 100% rate. And we've added the following CPT codes to the reimbursement list for family planning. There's chlamydia, we're adding all the STDs, chlamydia, GC, the syphilis, troponium, pallidum, the VDRL. We're also adding the hepatitis C antibody testing because we in Kentucky have a big issue with that, so we want to make sure that you're testing your family planning patients. Also, we're not paying for the HIV rapid test, but we are paying for the HIV confirmatory test. And the reason is that when we talked to the HIV program, they said that that code covers that test kit that they're providing for you, and they recommended that if we could, would we pray for the HIV confirmatory test. So there is that test. And then we're including the IUD Liletta, which is fairly new. That's the 3-year, like Mirena, only it's the 3-year. So those are the codes. You'll be getting a list within the next few days over what, we'll send out a list to the directors as to what the reimbursement amount is, and also with the added changes in the updated CPT code list that the family planning program is going to pay for.
And B, you may want to just reiterate that those are codes only if they're billed under the 802 cost center.
Right, I'm getting there, but thank you.
Okay.
This is only for Title 10 patients, for the 802 patients that are uninsured, and then of course it's adjusted according to sliding fee scale, for those who have a sliding fee issue there. But we will cover these for our Title 10 patients. It's also does not necessarily include what's covered under your Medicaid clients who you're billing for, and we're about to talk about that. Okay, so let's talk about the preventive fee schedule for Medicaid and an IUD update. First of all, we learned just in the last week or two that the Mirena CPT code has changed. It was effective January 1st, right, Christy? But we weren't told about it until a week or two ago. Anyway, the code is now the code that was on the PEF and that we've been coding as J7302 is now J7298. So for your Medicaid clients, make sure that when you're billing, you bill for the J7298. We'll pay either one through our Title 10 client, your Title 10 clients, to your 802 clients, but that's something that you'll want to make sure you update with your billing for your Medicaid and for your private insurance clients. Also, Skyla and Liletta are not currently on the Medicaid preventive fee schedule. Now, we will pay for them for your 802, your Title 10 patients, but Medicaid, we're working with the local health operations and with Medicaid to get this onto their fee schedule so that you can get paid for your Medicaid clients who get Skyla or Liletta. And just as I've got a couple of questions across my desk and on the phone and email that say, I have more than one person that needs an IUD, and you may think this is crazy, but the minimum that you need to provide a year is one. But with fee-for-service, you have the ability to provide implants and IUDs to more clients than one. And you're going to get reimbursed for them, and a lot of you are not spending. So feel free to take care of business with your 802 patients, because that is the most effective birth control method out there. And so you do have the ability to do more than one each year. And so that's just an update with that. And then the PEF update. There's codes that that either we've added or we need to update this. We're also working with local health operations to update the PEF. Meanwhile, you can write those codes in, and we will let you know when that updated, either us or local health operations will let you know when that updated PEF is available. But meanwhile, you can write approved codes in if they're not on the PEF. I checked with LHO and they said, yes, that'd be great. So that's what's going on with that. Okay, let's talk about QI updates and desk audits. We all love desk audits, but they're really important. And first of all, several of you have asked about these, and I wanted to let you know that Debbie Donovan, who was our QI nurse for the east side of the state, left her position last summer. Deb, if you're listening and on there, we love you. We miss you terribly. And we are in the process of, she's at Bourbon County now. So we are in the process of filling that position, and we'll let you know when that position is filled. Meanwhile, Gina Reed is still doing the west side of the state as the QI nurse for the cancer program, Women's Cancer Screening Program and Family Planning. Many of you on the west side hear from Gina frequently. Some of you on the east side have gotten some education from her. Gina's doing a great job. And so we will keep you posted on the new position when it's filled. Meanwhile, desk audits are still due on June 30th. Some of you have already submitted your desk audits for the year, and that's great. We appreciate that so much. We would like you to submit your desk audits to Melody Stafford, the KWCSP Program Director, at melody.stafford@ky.gov, okay? She will make sure that those desk audits get to the appropriate QI team member to be reviewed. And I know that desk audits are challenging for a lot of you, and I hear some grumbling, but you just need to know how important they are. Not only do they provide our federal partners who give us our money proof that we are doing what we're supposed to be doing in our clinics with our funding, but it also gives you an opportunity to make sure that your documentation is correct and that and helps you see your errors and correct them much more than if we were saying, you know, do this, do that. You know, doing your own review of those documents really has a benefit, and we would encourage you to make sure you get those in by June 30th. So you have a little while, but I wanted to get you planning about that. Okay, and then the other thing I'm going to tell you about is the family planning grant. We are in the process of writing our continuation grant in the next few weeks. I do dream of the beach, although now with Zika around, I'm going to make sure I stay in the United States. Anyway, but we're going to be writing that grant, and today we sent out an email asking you for some information about your service sites, your clinic hours. We do that every year, at least once a year, because the Office of Population Affairs wants to know that information. I have to include that in our grant. So as soon as possible, no later than March the 2nd, please send us any updates. If you don't have, if what we send you, what Christy sent you through Joy on the Tables are correct, you can write an email back and just say everything's correct, and let us know any changes, and we will make sure that we put those in as we submit our grant. We want you to send those to Tori Ambergy. Tori is our new family planning epidemiologist. We're really excited to have her on board. And her email address is tori.ambergy, AMBURGEY, @ky.gov. And Tori, and if you forget that, just send them to me, to Benita Decker. But, and we'll use that to get our grant in so we can get more money. Oh, there's her address. And does anybody have any questions? All right, there's my contact information. If you need to contact me for anything, I'll be there for you. And thank you for listening to me.
Thank you, Benita. Next, let's see here. Nope. Do we have the handout for the perinatal presentation that we sent out, Casey? If not, we send it out, we can refer to it. I'll go ahead and ask Trina Miller to come up. Trina is the program coordinator for the prenatal program here at the Department for Public Health. And she'd like to share information about an upcoming nursing CE that's going to be held on perinatal tobacco research and treatment. So thank you, Trina, and there's your handout for you. Okay?
Thank you.
Thank you. Sure.
There will be an upcoming opportunity, and you have the attachment that Joy sent out, and it has some pre-registration information on it. The event is March 16th, and it will be at Norton Healthcare Center in Louisville. And it is on perinatal tobacco research and treatment. Kristen Ashford from UK, she's a professor there, and she does a lot of work and coordinates our prenatal trainings for us, and has spoken many times in many different venues. But she's going to be talking about preterm birth and tobacco research, sharing some studies that she has done herself, talking about the electronic cigarette use during pregnancy, and also talking about perinatal tobacco dependence, some current evidence on treatment, and then also the GIFTS program, which is giving infants and families tobacco-free starts. And we have done this project in Eastern Kentucky several years ago. We have other health departments and counties that are implementing the GIFTS program now, and we just finished up in a second year Anthem grant that we have done also with GIFTS. This will be a free event. They'll be serving refreshments. It's put on with Norton Healthcare, Louisville Metro Public Health and Wellness Health Department, A1, March Dimes, and so all working together to put this event out there. And there will be 2 contact hours. And so on the flyer there, you can contact Janice Gibbs for pre-registration. Has her phone number and her email, and I've already contacted her and registered myself. And so just would like to invite you to participate in this. Also, as speaking of training in prenatal, we will be planning the prenatal and postpartum training. It looks like that event will be in May, and I have 2 dates, and we'll be sending the information about that out soon, and that will be in Lexington. And there will be a 2-day training for those who have not had the training or are working in health departments with prenatal clinics, and anyone else who would like to attend. There's RCEs associated with that also. And then we will be having a half-a-day update that will focus on substance use. So look forward to those attending, and if I can be of any help or assistance, please let me know.
Thank you, Trina. Melody, we have 2 minutes left. You want to talk about your mini grants?
Yeah, sure.
Okay. I'll invite Melody Stafford, who's the program coordinator for the KWCSP program, to step up. She's has a new mini grant application opportunity that she sent out recently, so I'll just let you invite everybody to apply for those funds.
Thank you, Joy. It's a pleasure to be here this afternoon. I just want to say, remember to get your Pink County mini grants in. We're giving out $10,000 per county. So if you're in a district, you can ask for $10,000 for each local health department. So we're very excited about this, as well as CDC. We have requested the same amount in our new grant that we're submitting here within the next week, and that will be for fiscal year 2017. So we were very fortunate to partner with Medicaid to get that data, and we certainly don't want to forget our KWCSP eligible women who are not insured at all. So if there's anything at all we can do to assist you in any way, please call me. I'm sure you all have my contact information. So do you have any questions at all? All right. Thank you all so very much, and have a great day.
Thanks, Melody. I did receive a question yesterday about if there was a limit to the number of local health departments who could receive the Pink County funds, and there is not. Actually, as you mentioned, we have the funds available, allocations available to fund all 120 counties. So, but you do have to apply for the funds, but there's not a limit for those dollars that are available to local health departments. So there's potentially a check out there for $10,000 for each county across the state.
That's right.
Right. Thank you. So that wraps up our February 18th Public Health Nursing ITV. Thank you so much to all of the presenters today, and thank you to each of you all out in the field for all that you do, taking care of your citizens and populations in need. And we will see you in April 16th. Take care. Bye-bye.